Good morning. Good morning to everybody who successfully connected to our TENS video workshop. I'm very pleased to welcome you all. It's already 10th edition of our traditional seminar, and I'm very pleased to announce that there should be, during these two upcoming days, about 90 attendees from many countries. Let me just briefly give you a rationale why it's conducted in this virtual format. At the beginning, we started with on-site seminars, and we wanted to give to participants hands-on experience. This was one of the most attractive parts of the seminar. But then soon we realized that it's very difficult, if not impossible. Even if you have 10 or 15 participants, to allow them to do examination on a patient, you can do it with one or two, but you cannot simply, it's unethical, impossible for many reasons to give them opportunity to really examine the same patient. We have to take into account that here we speak about patients with cancer, with very difficult situations. The examination is mostly vaginal or transrectal. So hands-on experience simply must be differently organized, and this is the reason why we have all the time 1 or 2 or 3 visitors with us who spend with us a few weeks, and then they can have hands-on experience. But it still does not explain why it's virtual. It's virtual because during the COVID era, we organized it for the first time virtually. And we agreed at the end of the seminar that actually virtual format was for this purpose, for the purpose of this seminar, if not equal, maybe even slightly better than physical experience, because it really allows us to have international speakers who are there in their countries and who will join us. It allows you to show you more patients, and still the interaction is there. And this is one of my practical notes, that all of you please use the chat. We will check the chat all the time, and we will try to answer or tackle all your comments or answers, even during the live scanning. So if you have any questions, you want to show something, some structure or anything to ask, please raise your hand, send us your remark, and we will be continuously searching for it and try to react. Then another practical aspect is that you received a program. There are times for breaks and for lunch breaks. You cannot rely exactly on the timing. Of course, it can flow a little bit. So don't rely on it completely. That the next session will start at 1. It can be 10 minutes forward, upwards, according to the real program, because we will be working with real patients, and really the basics is to give you as much as possible live scanning experience. So the aim of this seminar is really to go through the scanning, ultrasound scanning in all our main tumors. And for each of them, you will receive a little bit of clinical background. So what is really expected currently from imaging in a real clinical practice. Then there is always a theoretical lecture, which is very important for the field to have the same terminology and the same principles, and to give you also the overview of the literature of state of the art, and then will be the live scanning. Just to describe you how it looks like here. We are sitting in a lecture hall. In front of me, you cannot see it, but there is really a studio. So our lecture hall was transformed into the studio. A lot of PCs and screens and cameras. We hope that everything will be as smooth as it was last time. And we have international speakers who will join us, and we have also patients ready to serve as a real patients for live scanning. But also I'd like to emphasize that we will film everything, and we will send to all participants a link. A few weeks afterwards, please give us some time to review it, cut it, and make it available for you. But if you will want to come back to any lecture, you will have an access after the meeting. So that's also important to say. And now let me introduce one of my colleagues. My name is David Cibula. I'm chair of the department here, and I'm very pleased to sit here with part of our gynae oncology team. I'd like to emphasize that since 2004, thanks to mostly Daniela, we have really a very strong role of ultrasound in gynae oncology. So for us, it's absolutely the central of not the universe, but central of our clinical practice in gynae oncology. Number one, imaging modality, and in most cases we use another imaging modality only secondary after the triage made by the ultrasound. I'm sure you all know Daniela Fischerova, Professor Fischerova, who sits next to me and who is probably the reason, not me, but her, why you attend this meeting. And I'd like to ask her, Daniela, can you please introduce international speakers?
Yeah, with great pleasure. Good morning, good afternoon, good evening, dear friends, dear colleagues. It's my pleasure to welcome you here in this festive time before Christmas, and it's my pleasure to introduce our renowned speakers. Today it will be Wouter Freumann from Catholic University in Leuven. He is a professor at the Catholic University, and he will be speaking about diagnosis of ovarian tumors. Tomorrow will be starting by endometrial cancer, and Professor Elisabeth Epstein from Karolinska University in Sweden will be talking about endometrial cancer. After her, Antonia Testa, professor at Catholic University in Rome, will be introducing us to cervical cancer scanning. And lastly, Professor Georgia Garganes from Catholic University in Rome. She will be talking about lymph node staging in vulva cancer. And now it's my pleasure to move the microphone to my other colleagues, to Philipp Friehauf. He will introduce the patients, and Roman Kocian will be then also giving some informations about TrueCut.
Good afternoon, ladies and gentlemen. In this workshop, I will be responsible for the chat as well. So I can promise I will go through the chat conversation permanently, and I will try to answer the questions, and some of them I will select for the discussion. I would like to thank our patients who agree to participate in this workshop. We have altogether 10 patients which will be live scanned. Some of them will have TrueCut biopsy for you. There are 2 patients for normal anatomical scanning at first, then 2 patients for advanced ovarian cancer, and 2 for TrueCut biopsies for today. Tomorrow we can expect 2 patients for endometrial cancer, 1 for cervical cancer, and 1 with vulvar cancer, which will have ultrasound scan of the groins. So it's just about to clarify the program you can expect. And I can pass the phone to my colleague, Roman Kosian.
Thank you. Welcome all of you. I hope you will all enjoy the amazing ultrasound conference. And I would like to attract your attention for today's afternoon, late afternoon, when we will together with Philip do TrueCut biopsies, and I will try to give you some tips and tricks how to make the procedure quick, safety for the patient, comfortable for the patient, and very efficient. So looking forward to meet you late in the afternoon.
Well, Roman and Philip are examples that even this high-level oncogyne, as we call it, expert ultrasound, is possible to pass to somebody else, to teach. And they are very experienced oncogyne sonographers. And this is usually an argument when we discuss the role of ultrasound in some institutions where they don't use it, or they don't use it in a routine practice. They usually argue with me and saying, you have Daniela, so you are in a different situation. But my answer is no. It's not Daniela. It's Philip and Roman, and there are others, and there is the next generation, and it's the same like with any other method or technique or skill. You simply need some volume and then experience. But even to gather initial experience in our field, it's without risk, because you can still at the beginning use another technique, another method in parallel to check your accuracy, and only when you feel comfortable with the technique, you can switch from MRI or CT scan to ultrasound in certain situations. So I hope that this seminar will also help new sites and new experts who are now watching us to improve, and to some of them, start implementing ultrasound into the clinical practice. I can tell, as a clinician and non-sonographer, that I cannot imagine my life without ultrasound in these days. So that's we even have 3 helpers, visitors, international visitors. At least show your face. It's Daniela will introduce him.
We are very happy that we have all year coming new fellows from abroad. Recently we have, when I start here, with Natasha Sousa from Portugal, Umberto Scovazzi from Italy, and Reis Oliver from Spain. And they are with us about 3 to 6 months. They do their projects and they do a lot of hands-on training, and to be honest, they are becoming real experts after that time. So welcome here to our Ivugo workshop.
Thank you, guys. So as you can see, the mission is broader. The mission is really to spread the skills, not just the theory. But I believe, this seminar is really created to give you a very practical information. So I believe, even if you are not here, you will get the same experience. The only thing what you will not be able is to share with us lunch and breaks. So the beverage we have here is only for us. So that's it. Daniela, do we need to say something else? No. So probably you can introduce the first speaker and the first lecturer.
So it's my pleasure to introduce my dear friend, Wouter Freumann from Leuven. He is so much involved in all IOTA studies and in the development and validation of IOTA models on diagnosis of ovarian tumors. So Wouter, we are so happy that you take time from your vocation to spend it with us here for half an hour, and we are extremely grateful for your participation. Thank you very much. Please, you can start.
Thank you, Daniela, for your kind introduction. Do you hear me?
Excellent.
Hello, dear friends, Daniela, David, Philippe, and Roman. Congratulations ahead of this course on the beginning of the course already with your great organization of this event. I'm very happy that I'm invited to speak about IOTA. I'm speaking on behalf of dozens of investigators that have actually contributed to the IOTA studies. So it's not my talk only, it's many people are involved in the development of the IOTA study and the results that I'm going to present you today. So just a small introduction. When we talk about the management of adnexal masses, we want to know ahead of any intervention what kind of pathology we're dealing with. So first of all, patients with normal ovaries, they rarely need any intervention. Of course, they have normally no problems. Patients with functional cysts, they rarely need any surgery. Patients with benign tumors, they might need surgery, but there you can opt for minimally invasive surgery. And many patients with benign tumors, they can be managed conservatively. So this upper group of three types of findings, they can be managed by general gynecologists. On the other hand, you want to recognize the patients that have lesions that are suspicious, because they will benefit from being referred to gynecological oncologists. Moreover, patients with borderline tumors, they will probably be able to undergo fertility sparing treatment. They are also younger patients. Patients with invasive tumors, they will need more aggressive surgery. They will need debulking surgery and often also systemic therapy, depending on the stage and the type of tumor. And patients with metastatic tumors, they will have their treatment depending on the origin of the primary tumor. If it's a breast tumor or a pancreatic tumor that has spread to the ovary, the management will be completely different. But these patients should all better be referred to gynecological oncologists. And those are things that you want to know before you start any intervention. And this was the purpose of the IOTA study, to really improve the management of all types of adnexal pathology. And IOTA is an international group of dozens of centers that are enrolling patients in a standardized manner in subsequent phases. And it started in 1999. And several studies have been performed. Phase 1 until 3, they recruited patients selected for surgery. Then phase 4, those were investigators that were less experienced, so used to validate the models in less experienced hands. And IOTA phase 5 is a recent study that did not only include patients selected for surgery, but also patients selected for conservative management. And you see that thousands of patients have been selected in a prospective way in these studies. How did we recruit a patient in these studies? So the first thing that you should know for any type of assessment by ultrasound is that you should use standardized descriptions, standardized definitions, and standardized ways to measure things. It's important for your medical report to be able to understand, if you follow up patients after a year or 2 years, that you still understand what you really meant with your description of last time. Also, when you discuss patients with your colleagues, when you discuss patients with the surgeons, but also, most importantly, when you do multi-center studies and multi-center trials, it's very important that in every center, the same terminology is used to recruit and describe findings of ovarian tumors. We'll go through some of these features that we should all know before we start assessment of adnexal tumors. The first is a definition of a lesion. It's only the part of the ovary which is not consistent with normal physiology. So sometimes you will see in the ovary that you still have some follicles, that's normal physiology. But the lesion is only the part of the ovary which is not compatible with the normal physiology. In some tumors, there is no normal tissue visible, there's no normal stroma visible, and then the lesion will be the same as the ovary. You see no normal stroma left. So here the lesion and the ovary is actually the same. When you have a part of the ovary which is consistent with normal physiology, it's not a part of the lesion. Like here in this patient, which is premenopausal, you have a corpus luteum cyst that is not described as a lesion. So first we know the definition of a lesion, then we can go ahead with the definition of a solid component. It's a quite easy definition. It's a structure that has, in general, a higher echogenicity, which is suggestive of tissue, like the echogenicity that you can see in myometrium, in normal ovarian stroma, myomas, or fibromas of the ovary. These are all examples of solid components, as you can see. They might be big or they might be small, like in case of these papillations on the right side. There is one exception to this rule, and it's the white ball in a dermoid cyst. So if you have a Rokitansky nodule, so it's a ball of hair and sebum in a dermoid cyst, and you recognize it and you're confident that it's a dermoid cyst, you will not describe it as a solid component. That's the exception to the rule. Then it's not solid tissue, it's not a solid component. But if you are in doubt, you always have to go for the worst case scenario. And if you are in doubt, you're not sure that it's a dermoid or a teratoma, then you need to report it as possible solid tissue. On the other hand, blood clots, also amorphous material, is not described as solid tissue. So here you can see a retracted clot, here you can see the fibrin threads. These are not solid components. So there are two tricks that you can apply to distinguish between real solid tissue and blood clots or amorphous material. So first of all, don't forget, it's an advantage of ultrasound over MRI and CT scan, is the dynamics of the ultrasound. You can push with the probe and you can see things sometimes move. On the left side, these are two blood clots. If you push with the transvaginal probe, after warning the patient, you can see that you will see that there is movement inside these cysts. So that's as a blood clot which is moving in a jelly-way fashion. Then you're sure it's not a solid component. You can also use color Doppler. If you have some color Doppler inside some part of a tumor, you're sure it's a solid component. If you don't have any color Doppler inside, you're also more certain that it's perhaps not solid tissue, but then you have to pay attention because there are some pitfalls. Sometimes the lesion is too far away from the probe to detect the vascularity. Sometimes the lesion is just too big to detect the vascularity, or the settings of your uterus machine, ultrasound machine, are not right. Your sensitivity for blood flow might be too low, and you might not detect the vascularity. So presence of vascularity, presence of blood flow is diagnostic for solid components, but absence of vascularity is not always sure that it's not solid tissue. So pay attention with that. But if you are in doubt, you always have to go for the worst case scenario, and then you have to describe it as a solid component. A specific subtype of solid components are papillations or papillary projections. And it's that type of solid component which is starting from the wall of the cyst or from a septum, protruding inside the cyst cavity with a height of at least 3 millimeters. So if you have this, you have a papillation. And if you have a papillation, you have by definition as well a solid component. So these are examples of papillations. So they are protrusions from the wall or from the septum with a height of at least 3 millimeters. If the height of this protrusion is less than 3 millimeters, we're not talking about a papillation, we're talking about a wall irregularity. There are not only papillations that are solid components, you have other types of solid components like this. It's not protruding, it's more a concave margin. It's not protruding inside the cavity of the cyst. This is another type of solid tissue, which is not a papillation. Another definition you need to know to classify ovarian tumors is the definition of a septum. A septum is a thin strand of tissue running from one side of the cyst surface to another one in all scanning planes. So it's not interrupted in any scanning plane. From the moment you're scanning dynamically and you see that the septum is interrupted, like you see here, it's not complete. Then you have an incomplete septum, and incomplete septa you can see often in diseased tubes like in a hydrosalpinx. So a septum as such is complete in an uninterrupted in every scanning plane. From the moment it's interrupted, it's no longer a septum, it's an incomplete septum. These are examples of incomplete septa in a hydrosalpinx. So when you know the definition of a lesion, you know the definition of a solid component, of a septum, papillation, you're able to classify each ovarian tumor in one of these 5 groups: unilocular, unilocular solid, multilocular, multilocular solid, and solid. I will show you examples of each of them. So first of all, the most easy one, unilocular, has only one cyst locule. There are no septa, but a pseudoseptum or an incomplete septum is allowed because it's not splitting the cysts in several locules. If it's incomplete, it might be still unilocular. but no complete septum is allowed in a unilocular cyst. And you cannot have any solid components, so no papillations, no other solid component is allowed. On the other hand, any type of content is allowed. It may be ground glass, hemorrhagic, anachogenic, so any type of fluid is allowed in unilocular cysts. Second, unilocular solid, it's a little bit the same. You don't have any septum. A pseudoseptum is allowed. But in addition, you have at least one solid component. That might be a papillation or some other type of solid component, as you can see here. So here, these are all unilocular solid tumors. More examples of unilocular solid tumors, which often have papillations. Third, multilocular, no solid component at all, but at least one complete septum. So again, running in all scanning planes uninterrupted. And any daughter locule is also allowed. So daughter cysts, so in the wall of the largest locule, you might see smaller locules. It's also dividing the cyst in several locules. It's also making it multilocular. If you don't have any solid components, we call it multilocular cyst. More examples of multilocular cysts with more locules, as you can see here. Fourth group is multilocular solid, so it's the combination. You have at least one complete septum and at least one solid component. That can be a papillation or, again, another type of solid tissue, like you can see here or here. So multilocular solid. And then more examples, multilocular solid tumors with larger solid components. And then the fifth group is the group of the solid tumors. These are tumors that are at least 80% solid. So not 100% of the cyst needs to be solid. If at least 80% of the tumor is solid, we talk about a solid tumor. So in fact, also solid tumors might contain cystic areas with or without papillations, as you can see here. So at least 80% solid makes it a solid tumor. These are examples of solid tumors. They can be completely solid, or as said before, they might contain cystic areas. Why is this so important? This very basic morphological classification is already associated to the risk of malignancy. A unilocular cyst has a very low risk of malignancy, luckily, less than 1%, 0.6% on IOTA phase 1. On the other hand, you see that the risk will increase with the complexity of the tumor. And in solid tumors, around 60% of the tumors that are solid will be malignant in the end. That's about the morphological classification. Now we will talk about the content. We have anachogenic, if there's no reflections inside, if it's just a dark content. Low level, when you see very small dots, mucinous content, and these dots might often move away from the probe. Also, if you put on color Doppler, you might see acoustic streaming. You see the small reflections moving away from the probe. Then you have hemorrhagic content, when you see blood clots or fibrin threads. Ground glass, if it's more homogeneously hyperechogenic, as you know in endometriomas. Mixed content, when you see very heterogeneous content, like very hyperechogenic and hypoechogenic areas, is typical for absidations and dermoids. I will show you on the next slide more real ultrasound examples. So first, anachogenic, there is no reflections at all. It's just a dark content. Low level, when you see small dots, and as I said before, they will tend to move when you look with the ultrasound probe here. They will move away from the probe, and they will more especially move away from the probe when you use color Doppler. Hemorrhagic, when you see really the fibrin threads, they often move if you push against it, like gel. You will see that it's like hemorrhagic. Mixed content, here you see hairs and dots and a Rokitansky nodule, and here you see shadows. That's typical for dermoids. And then ground glass, it's more homogeneously hyperechogenic. Again, anachogenic, low level, hemorrhagic, mixed, and ground glass. Another important feature is the feature of acoustic shadowing. Acoustic shadowing is a loss of acoustic signal behind a sound absorbing structure. Like here, this is an ovarian fibroma. You can clearly see fan-shaped or stripy shadows in this direction, so from the probe away irradiating. And then here you can see clear shadowing behind this Rokitansky nodule in this dermoid cyst, or very tiny shadows here in this dermoid, and also very subtle shadowing in the cystinofibroma behind cyst wall irregularities. You might see also that there is some shadowing presence. So again, very obvious shadowing, as you can see here. or very subtle behind this wall irregularity. And just to let you know, it's not only benign tumors that have shadows. So this is a Krukenberg tumor that has spread from the ovary to the ovary from the stomach. Also, malignant tumors can contain shadowing. So it's not because you see shadows that you're sure it's benign. Also, malignancies can contain shadows. The next feature that is important is the irregularity of the wall. To look at the irregularity of the wall, we usually look at the inner lining. We only look at the inside of the cyst. And when you see wall irregularities or papillations, for instance, or calcifications, it might make the wall irregular. When you have a solid tumor, we will not only look at the lining of cystic areas inside, but we will also look at the outer contours of the lesion. So solid tumors are exceptional because for irregularity of the wall, you will look at the inside, but also at the outer contours of the lesion. These are examples of irregular tumors. So for most cysts, so unilocular cyst, unilocular solid cyst, and multilocular solid cyst, you will only look at the inner lining. When you have solid tumors, you will also look at the outer contours of the lesion. So this is an irregular tumor because it has irregular outer lining, but some tumors that are solid have also cystic areas which can be irregular, as you know. And then another feature is ascites. It's not only a little bit of free fluid in the pouch of Douglas, which is making it the presence of ascites. No, ascites is also fluid above the fundus of the Douglas, the fundus of the uterus, above the Douglas, so behind the bladder, or also in Morrison's pouch in the upper abdomen, you might see free fluid. Then you are dealing with the presence of ascites. Then color Doppler, it's also important to discuss this. It might be very subjective, so there is some objective way to describe it. Color score 1 is no Doppler vascularity at all. Color score 4 is maximal vascularity, so abundant flow. Color score 2 is if you really have to search and to find something of blood flow. And 3 is intermediate, so it's in between. So 1, 2, 3, and 4. These are examples. 1, no color in the lesion, but outside the lesion, of course, in the stroma of the ovary or in the pelvic vessels, you can see some vascularity. We only describe the lesion itself. So 1 is no Doppler flow. 4 is abundant. It's very throughout the lesion. 2 is minimal. And as I said before, 3 is intermediate. So it's important, if you look at vascularity, that you standardize the settings on your machine. You have to maximize the sensitivity and the detection for flow without having too much artifacts. There are 2 buttons that you need to know when you look at Doppler. You need to look at the PRF, the pulse repetition frequency. It should be set at 0.3 or 0.6. If you put it too high, you will have a low sensitivity for blood flow and you will underestimate the vascularity of your lesion. So this is 6 times the same lesion, but the settings are different. So you have to try to find your PRF and set it on 0.3. That's preferable to assess vascularity. Second button is the one of the gain, because if you put the gain too high, you will have a lot of artifacts. So you have to put the gain first up until you have artifacts, and then you turn back the gain until the artifacts just disappear. And that's the correct level of the gain to assess the vascularity. How do you have to measure things? It's 3-dimensional. We see 3-dimensional structures, so you have to measure things in 3 dimensions. As you know, you have to start with the largest diameter of the ovary or the lesion, and then you measure the other 2 diameters. So you have 3 diameters in total. There's one exception to this rule. That's the measurement of a papillation. There you start with the height, and the height is measured from the inner lining of the cyst. So the thickness of the wall is not taken into account. You start at the inner lining of the cyst, and you go until the tip of the protrusion of the solid component. So that's the height. So the height is the first measurement, and then you take the 2 base measurements, as you will see here. So base 1 and base 2 in the other direction. Everything is really nicely written in pictograms that are found for free on the IOTA website that you can access. And also the group of Daniela and Adam Preisler in Prague have made very nice drawings of this that are found on the website of IOTA that can be downloaded to help you in clinical practice. So when you know these definitions, you can really start and go ahead with making a proper diagnosis. The things that you can apply to distinguish between benign and malignant are first your experience, your pattern recognition, how you recognize things based on your experience. That's subjective assessment, but that's hugely depending on your experience. If you're very novel and you just graduated and you just started as a gynecologist, your subjective assessment will not be so great. It will become better when you see years patients with ovarian tumors on ultrasound, and you also know the outcome. So that will improve your subjective assessment. But it's not fair that you need to work a long time before you have a good experience, and then only then you have a good performance to recognize malignancy. So to give everybody the opportunity to have a good performance to recognize malignant from benign, there are some tools that you can apply. You have the risk of malignancy. It's already quite old. It's developed in 1990, and it's still used in many countries, but actually it's a little bit past now, because there are novel IOTA techniques that I will discuss with you that are much better to distinguish benign from malignant. There are many tools available. You have the simple rules, the descriptors, that next model, LR1, LR2. But I will focus on 2 today, because we think as an IOTA group that those are the 2 most important tools to be applied in clinical practice. And it's the use of the simple descriptors, first of all, and second, the use of the UpNext model. What is the UpNext model? I will start with this one. It's the first existing model in diagnosis of adnexal tumors that is not only able to distinguish between benign and malignant, but that will also tell you the subtype of malignant tumors. It will tell you the risk that the patient has a borderline tumor, a stage 1 invasive primary ovarian cancer, stage 2 to 4 primary invasive ovarian cancer, and a metastasis from another origin that has spread towards the ovary. So it's a multi-class prediction. It will tell you the risk of multiple subtypes of malignant tumors. How does it work? Well, it's based on some features that are known in the IOTA database to be specific for the subtypes of tumors. We know that from these almost 6,000 patients, that C125, of course, will be higher in stage 2 to 4 cancers. On the other hand, solid tissue, you will see it more often in malignancy. Papillations, you will see it more often in borderline tumors and in stage 1 invasive cancers. Acoustic shadows, on the other hand, you will see it more often in benign tumors. And ascites, you will see it more often in advanced stage primary ovarian cancers and also secondary metastasis. So there are some tools that can help you, that can make you give you a calculation to calculate the risk of malignancy. And that is how UpNext works. It's a logistic regression model based on some specific clinical features and ultrasound features. There are 3 clinical features: the age of the patient, the type of center, and serum C125. You don't need C125 to calculate the risk of malignancy. It's an optional variable. It is not necessary to calculate the risk of malignancy, but it will help you to stratify in the malignant subtype. So if the risk of malignancy is increased, then adding C125 will help you to tell you what type of malignancy the patient has. And then there are 6 ultrasound variables. They're quite easy to be collected. You don't need a lot of time and experience to collect them. It's a maximal diameter of the lesion, the maximal diameter of the largest solid component, so both in millimeters. And then there are some questions. Does the tumor has more than 10 cyst locules or not? Yes or no? What is the number of papillations? Are there 0 papillations, 1, 2, 3, or more than 3? Do you have any acoustic shadows? Yes or no? And do you have ascites? Yes or no? So very easy questions, very easy to be collected and to use the model. And as you can see, there is no color Doppler inside the model, just to improve the easiness of use and to avoid inter-observer variation. So you have the features. Now you can add the formula. As you can see here, you can calculate the risk of malignancy. Of course, it's crazy. Nobody can use this. It's a very complicated formula. It's a mathematical model. So you need some assistance. So you can use the formula on the IOTA website for free. You can add all the variables and you can calculate, like in this patient, the risk of malignancy, which is highest for borderline. It's more easy actually, so you can use also the software because it's integrated in quite some ultrasound companies' machines. So when you scan the patient, you can open the module of UpNext and you can add the age and the type of center, which are also usually automatically filled in. And then you can measure on the spot the lesion diameter, the largest diameter of the largest solid component. And then we add the questions. So are there more than 10 locules? In this case, no. What is the number of papillations? In this case, there are 2. Do you have shadows? Yes, we have shadows. We have no ascites. And as I said before, C125 is not mandatory to calculate the risk of malignancy. So here, we don't need to fill it in, and we can automatically immediately calculate the risk. And for this patient, the risk of malignancy was around 10%, as you will see. So it's a very good performing model and very easy to use. I will show you another case, a unilocular solid tumor with a large population, quite some vascularity inside. It was 9 centimeters, a 5 centimeter solid component, no shadows, no ascites. Again, largest diameter of the lesion, the largest diameter of the largest solid component. 82% risk of malignancy. It's way above the cutoff. So the suggested cutoff to indicate an increased risk of malignancy is 10%. So here it's 82, it's much higher than the cutoff. And then in a second step, you can look at the subtypes of malignancy, and you see that stage 2 to 4 has the highest absolute and relative risk of malignancy. But this is without C125. So if you add C125, in this case it was 25, you see that the risk of malignancy is still very high, still above, much above the cutoff of 10%. So it's not much lower. And you can look at the subtypes of malignancy now. You see that stage 1 invasive has now the highest risks. So let's see what the outcome was. The patient was operated on, and it was a stage 1 invasive endometrioid adenocarcinoma. So with C125, the model was better to detect that it was a primary invasive ovarian tumor. How does ADNEX work? Then we look at the AUC, the area under the curve, the area under the ROC curve. You can see that the model has been validated in many different centers on thousands of patients. And the summary AUC is above 0.9. So it's a very high area under the curve to distinguish between benign and malignant. So it means a very good model to distinguish between benign and malignant. So that was on patients that were operated on. Now we look at IOTA 5. You remember that it's a study not only collecting patients undergoing surgery, but also patients in conservative management. So on this study, we could see that on almost 5,000 patients, and we looked at the performance. So on all types of tumors, also conservatively managed, you can see that ADNEX, with or without C125, it's actually the same, 0.94 AUC. It's better than, for instance, the risk of malignancy index. So ADNEX is the best performing and existing model at the moment to detect malignancy in patients. Do you need to use the ADNEX model on all patients? Well, no, because we know that some tumors are very easy to be recognized as benign. You have the endometriomas, you have the dermoid cysts, you have the cystadenomas. Some of them share these features, which make them very easy to be recognized. And that's why we introduced the two-step strategy. So to avoid that you need to do calculations on all patients, we can first sort out the very easy ones, the endometriomas, teratomas. And in the second step, when the descriptors do not apply, then you can use the ADNEX model. What are the benign descriptors that can select the easy cases? So cases where you don't need to do any calculation. There are 4 of them. The first one is the presence of a unilocular tumor with ground glass echogenicity in a premenopausal patient in a diameter less than 10 centimeters. That's suggested for the presence of an endometrioma. The second one is unilocular tumor with mixed content, shadowing, and less than 10 centimeters, as you know, is suggested for a dermoid cyst, a teratoma. And then the 2 below are unilocular, anechoic, or other types of content with regular walls and smaller than 10 centimeters. So that's suggested for the presence of a cystadenoma. So you see, these are very easy to be recognized as benign. And you can apply these in almost half of all ovarian tumors. So most ovarian tumors are very easily diagnosed as benign using these benign descriptors. And in the second step, then in the remaining, you can use the ADNEX model. And this is really new. This is from last month, published in the White Journal. It's the performance of the two-step strategy. So first, the benign descriptors, and second, the ADNEX model. And you can see that with or without C125, the AUC is also very high, and 90.95, 0.94. It's an excellent performance to distinguish between benign and malignant. And this is actually the same AUC as we just saw if you would apply ADNEX on all tumors. So the two-step strategy has the same excellent performance to distinguish between benign and malignant. I'm almost at the end of my talk. These are my preliminary conclusions. So first of all, when you do assessment of adnexal tumors on ultrasound, you need to be aware of the standardized definition, the standardized terminology and measurement methods. Second, ADNEX at this moment is the best model that exists to distinguish between benign and malignant. So it has superior performance, superior AUCs compared to other existing tools But besides that, the model can also predict the risk that there is any of the 4 subtypes of malignant tumors, being borderline, stage 1 invasive ovarian cancer, stage 2 to 4 invasive ovarian cancer, and lastly, a metastasis from another origin that has spread to the ovary. So it can predict the risk of these 4 subtypes of malignant tumors. You cannot use the model in your head. It's too complicated. You need a calculator. It's freely available on the IOTA website, on an app that you can download on your smartphone, and it's also built inside ultrasound machines. And the combination of ADNEX after using the benign descriptors to recognize the easy benign cases is called the two-step strategy. So first the benign descriptors followed by ADNEX is the two-step strategy, and you have seen that the performance of this two-step strategy is the same as you would apply ADNEX to all tumors. So excellent performance. Lastly, the integration of the benign descriptors and ADNEX is also accepted now in international guidelines to manage patients for diagnosis of adnexal tumors. You know the ORATS groups, ORATS 1, 2, 3, 4, 5. So ADNEX can be used to stratify the patient in the right group, and depending on the group, you have a suggested management protocol. That's the ORATS system, and this system has also been now accepted in an international guideline for management of patients with adnexal masses, endorsed by ESUOC, ESGO, ESGE, and IOTA. So first ultrasound, if you have excluded the physiological findings, you can use an expert or ADNEX to assign the patient in the correct risk group, and depending on the risk group, you can select the proper management. That's the first step to distinguish between benign and malignant, to know whether or not you need to refer the patient to a specialized gynae-oncological center. And then the second step, you can use again the expert on ultrasound or ADNEX with C125 to select the correct subtype of malignancy with additional tumor markers, additional imaging, staging procedures, and you will end at the right diagnosis and the right management. So this was my talk. I would like to thank you for your attention, and I'm very available to answer any questions. Thank you.
Thank you, Walter. Can you hear me? Yeah, thank you, Walter. It was, once again, thank you. It was a really magnificent summary of the state of the art for ultrasound differential diagnosis of all adnexal masses. So I'm looking at the chat. If there's any question, there's nothing. But maybe one question from my side. What do you think? What's the future of these models? I think they are validated. They have good diagnostic performance. So what to do now? Try to spread them into our gynecologist population.
Yeah, we're trying to spread them a lot with the courses that we give and the trainings. But now there are some projects going on. For instance, we are looking at how they work in pregnant patients. We are looking at how they work in adolescents and teenagers. So these are things that we don't know, but these studies are ongoing. We're also looking at if ADNEX, it's actually developed on IOTA phase 1, 2, and 3 data, so on almost 6,000 patients. But in fact, in the meantime, there are 40,000 patients in IOTA. So maybe it's time also to update the model, to adjust the weight of the variables. For instance, we know that acoustic shadowing with old ultrasound machines, it was seen most likely in dermoids when it was very easy to be seen. But now with the newer machines, we will see shadows often in malignancies. And perhaps we will need to readjust the model to be modern enough, and also perhaps to see whether we should include other variables, or even to make the model flexible. So now we have 9 variables in total, but maybe we can use ADNEX with whatever information we would have to make it like if you would have family history or personal history of the patient, or you would have other features available, other biomarkers included. So there are much things that you can do the larger the database gets to make the model better and more sophisticated, but still easy to use. So that's one thing that is that the group is working on. We're also looking at maybe the use of AI. Yes. So AI to help the user to detect features, so that ADNEX can work with given suggestions that the machine can give you, like in fetal biometry, that the diameter of the skull and from the femur can be detected. It's the same that we can do with ultrasound with diagnostic tools. So these are examples of things that we are still working on. So it's definitely not the end of IOTA and its tools. It's we're just still ongoing with a lot of different projects.
Okay. So thank you once again. So we would appreciate if you stay connected with us. We will have a live scan now, and there will be another discussion after that. So we can proceed to live scanning. We have one healthy volunteer who agreed to participate in this event. So we should now see the scanning of the pelvis and abdomen in a healthy young woman with no disorders, no conditions. So please, Daniela, can you hear me?
Yes.
Okay,
yes,
so
I can hear you. What about you?
we can hear you,
Yeah.
and we can see the screen, so
Perfect.
everything is working.
Perfect. So first of all, I would like to thank Wouter very much. He is on vacation. He is on holidays. So I think we will manage the further discussion without Wouter, and we would be very happy if he can enjoy the holidays, and lot of regards to his family. And we will manage the live scans together with Philip Wouter. So certainly you can now enjoy your free time. Thank you very much.
Thank you, Daniela.
Thank you.
Thank you, Philip.
Thank you. Thank you for all. So now we will be focusing on the live scan. So here, just to get oriented, I insert the probe in the vagina in a young patient. She was sent for an ovarian cyst. So she has here, this is the cervix, just to get oriented. Here is the bladder, and there is the rectum. So I insert the probe first to the anterior fornix, just to look how is the uterus mobile against the bladder. And the patient, she is newly gravid. She is now using the hormonal contraception. I will tell you later on why. So, and now I insert the probe in the posterior fornix, and I can see that the cervix is nicely sliding against the rectum. And also, if I push slightly with the probe against the uterus, we can see that it also slides against the sigmoid colon. Or I can use my free hand and do the same maneuver like here by pushing with the free hand slightly against the fundus. So the uterus is anteverted flexed, and we start the examination. So here we start by the external cervical os. We have the endocervical canal. Here are some ovula naboti by the internal cervical os, and we continue to follow this thin strip of the endometrium. This is the endometrium, and in the midline, this is just the mucus, and you see that it's beautifully straight. It's without any waves, so it also some marker of the uniformity of the endometrium. So this is the midline, which is forming by the mucus, and the endometrium on both sides is uniform, very thin, and the endometrial myometrial junction is regular. This is this hypoechoic line. Then we have the myometrium with the internal, the midline or the middle part, and the outer part where are usually the arcuate vessels here, which are then becoming radial vessel, and then spiral vessels. But these spiral vessels we cannot see because the patient has only the basal layer of the endometrium. She's using the hormonal contraception continuously. So now we move to the right. We just follow here the ligamentum ovarii proprium. And here we are on the right side by the ovary. There are a few follicles, and we will check the mobility again against the pelvic side wall, against the uterus. And here would be probably the part when we would also expect some part of the tube, of the right tube here. We can also look here. So the tube is very thin, is not dilated. This will be the fimbrial part of the tube. Probably there is no free fluid, but I will show you the next patient with dilation of the tube. And we move to the opposite side. And on the opposite side, this is the ovarian cyst. And these are in, this is multilocular cyst. So here is probably septum, here as well. So we have probably 3 locules in the multilocular cyst with very dense material. We would call it probably regarding the echogenicity, ground glass echogenicity. This is avascular cystic content, which is corresponding to this Sampson cyst content, which is like chocolate cysts. So here, there. And here is the residuum. Sorry, I will put to the power Doppler. So here is the residuum of the ovarian tissue. And this was the reason why the patient was referred. And we will check whether the ovary with this multilocular cyst is mobile. It's a little bit fixed perhaps to the pelvic side wall. And I am also wondering whether there is not any connection with the cervix and the posterior ligament. So now, just to get oriented, I insert the probe here to the posterior fornix. Here I have the rectum, and here you will see the cyst, the endometrioid cyst, and this is the position. This is the cervix. This is the position when we are evaluating usually the rectovaginal ligaments, which are the part of the posterior ligament. So there are no nodules, no signs of infiltration of the left uterosacral rectovaginal ligament, and the cyst is not attached to the posterior ligaments. But now we will also check the association with the left ureter. So this is the bladder. Here we will try to identify the trigonum. I just look here slowly. Here I will have the ureter. This is the ureter coming here from the trigonum, the left side. And we will follow here the left ureter around the cyst. And you see it's really in close proximity, the left ureter, but it's not in some stricture or adhesions with the endometrial cyst. But this is the reason, you see now the peristalsis, this is the reason why you can have also like occult hydronephrosis in the patients with endometriosis, because after the years of endometriosis, the ureter is then attached to the endometrioid cyst, and there is a stricture and the hydronephrosis, hydroureter, and sometimes the patient is even coming with afunctional kidney due to endometriosis. So here you see the close proximity, but it's still normal peristalsis, normal diameter of the ureter. And we will go once more in the anterior compartment. So we know that regarding the endometriosis, we have the left side endometrioid cyst. We have checked the left ureter. We can also go through the midline to the right side. So here we'll be running the right ureter to the pelvis and in towards the kidneys. And there are no signs of deep endometriosis in the anterior compartment, in the dome or in the base and in the dome of the bladder, which is the usual place. And then we will also check the posterior compartment. So we start here by the anum. We can see the sphincters, sphincters, excuse me. And then we continue here with the probe to follow the rectovaginal ligament. This is the echogenic tissue. And this is the subperitoneal rectum. And we have already here examined the rectovaginal ligaments, which are free of any nodules. And we stay here on the rectum, which is then becoming here sigmoid colon. And we will follow not only the anterior part of the sigmoid colon, but also the posterior part. And here is the sacral bone. So also the sigmoid mesocolon up to the part when the colon is leaving the pelvis as a descending colon, which is this part where we have already the external iliac vessels, and this is the sigmoid colon just crossing over here the iliac vessels. You see here, you know already the endometrioid cyst. So we know here that we have here no signs of adenomyosis. She is using the hormonal contraception with Dienogest. She started last month. Due to endometrioid cyst, she doesn't plan family now, so she is on the hormonal contraception treatment. She has mobile uterus, mobile right ovary. The right tube is not dilated. On the left side, there is this multilocular endometrioid cyst. Also here I have checked before the part of the tube which would be here. I have also seen a very small cyst on the fimbrial part of the tube. I try to show it. It was probably there. This is the cystis morgani on the fimbrial part of the left tube. And the tube is not dilated. And we have seen that the ureter, which is there, is in the close proximity here of the endometrioid cyst. You see it here. And you have seen the rectum and sigmoid colon without the signs of deep endometriosis. And lastly, we always look on the pelvic side wall, so we can start, here is the bladder by the cervix. So I will go to the cervix in the sagittal plane. I turn the probe 90 degrees counterclockwise. You have here the uterine vessels, and you just follow the uterine vessels there to have the internal iliac, and you follow the internal iliac vessels. You have here this is the superior and inferior gluteal arteries and the vein. Oh, it's a little bit painful. I will wait because of the shadows of the colon. It's a little bit difficult, but here you have the external iliac vein, and here is the artery. I just will show you here the pulsation of the artery. And here are the internal iliac vessels. So the internal and the external. And I go to the opposite side and just the same procedure. So here we have the internal iliac vessels. Here they are. And I will show you, this is the external iliac vein, external iliac artery. And here you will have the interiliac bifurcation with the internal iliac artery and the vein. Here is the superior gluteal vessels, inferior gluteal vessels, and you continue to the cervix, to the uterine vessels. So we can visualize the internal iliac. Here they are. And the bifurcation with the external iliac. And if you allow me, I will continue with the transabdominal scan now. Is it possible?
Questions from our chat. We could see it quite clearly, the whole pelvis, so we can proceed to transabdominal scan.
We can proceed. Yeah.
Sorry, there's one question from audience, from Professor Cibula.
Daniela, maybe I missed that, but did you show ureters?
Yeah, both.
Okay, so this was my mistake. I'm sorry. Okay.
So we go to abdomen. So now you will see also, I will ask the technicians whether they can also switch the external camera input, that we will also show where the probe and how the probe is oriented. Natáhněte nožičky. So now, Philip, can you see also the camera?
We can see the camera, but we can see just you and not the position of the endovaginal probe. So maybe
abdominal probe.
Yes.
Do you see the abdominal probe now, where it is located?
So could you please turn the lights a bit more on?
Okay.
Everything is in dark, very dark, so it's the only problem. However, we can see the ultrasound screen, and
Danielko, museli byste dát kameru trošku níž, ale zase, aby nebylo vidět, kdo to je. Jo, teď už to vidíme.
Okay,
jo, teď už to vidíme. Super, skvělý.
Okay, so now I am using the convex array probe, and I start, as you see, in the left upper quadrant. I can start whenever I want, but I always start here just to do the systematic examination. So first, I ask the patient to take a deep breath, to visualize here. This is the larger curvature of the stomach. Here is the cardia. This is already the heart. Cardia. This is the stomach. So here you have the possibility to see the gastrosplenic ligament. Then when I skip the probe a little bit dorsally, I will have here, this is the spleen here with the splenic hilum. And if I go dorsally, I will also see the left kidney on the psoas major muscle here. And you see there is parenchyma, the pelvis of the kidney is not dilated. We have seen the ureter, the left ureter, in close proximity of the endometrioid cyst, but the kidney is absolutely normal. And when I ask to take a deep breath, you see that the kidney slide up and down about 6 centimeters. Prosím ještě jednou. So it moves there. And here is the spleen. And now I will go to the right side. I am in the sagittal plane, and this is the right kidney. And it's located here on the psoas major muscle, which is there. This is the psoas major muscle. This is the right kidney. The echogenicity of the renal parenchyma is identical to the liver, or is usually less echogenic than the liver. And I go in the sagittal plane very slowly to the midline. So first you will see the distal part here of the duodenum. Then the gallbladder, which is almost empty because the patient is after the perhaps slight light lunch. This is the distal part of the duodenum, and here is the descending part of the duodenum. And this is the pancreas. So you can beautifully see that the duodenum will be running here like the C-curve around the pancreas. I go more to the midline, and I will be here by the pylorus. I wanted to show it to you. First, perhaps this is the pancreas. Here is the duodenum. Here is the antrum of the stomach. And you see the duodenal bulb and the stomach. And from the stomach, you can see in the slightly oblique section, you can see even here the abdominal part of the esophagus, the cardia, you have seen it already through spleen, the corpus, and now the antrum, and this is the pylorus, the muscle ring between the antrum and the duodenal bulb. And we go here around this is pancreas, around the pancreas. So we can here, I will wait that you see the content of the duodenum around the head of the pancreas. Once more, this is the corpus and the tail of the pancreas and the head. And then I go to the subcostal and transverse view to visualize, to visualize here the 3 hepatic veins, which are confluenting to the cava. So we have the middle, the left, and the right hepatic vein. And the middle hepatic vein is dividing the liver into the true right and into the true left liver lobe. And then we have the portal vein, which is like horizontal plane cutting the liver here. This is the right and the left portal vein. And it's helping us to divide the liver in the subsegments after. So this we continue to examine the liver parenchyma, but also the surface of the liver and the diaphragm up to here to the Morrison space. And we will go again to the position to evaluate the omentum. And we start here by the first, the hepatoduodenal. This is, the duodenum, pancreas, liver, so hepatoduodenal and hepatogastric lesser omentum. These two ligaments are forming the lesser omentum, hepatoduodenal part and hepatogastric. And then we have also the greater omentum. And the greater omentum starts by the greater curvature of the stomach and is hanging down around the transverse colon. Here is the transverse colon. So this is the supracolic part above the colon. And then around or crossing the transverse colon should be hanging to the pelvis as infracolic omentum. But I have a very slim model, so you will not see really omentum because she doesn't have any fatty tissue in her body. So this is the part where we examine the omentum, and we move now to the paracolic gutter. This is how we examine systematically abdomen. So we start here by the right paracolic gutter and we follow the ascending colon. This is the abdominal side wall. And we follow the ascending colon to the ileocecum, which will be here. I am just, because she has very long colon, this is unusual long. It's coming up to the pelvis, which is usually not so long. And here will be already the ileum, I would expect. So it's unusually long one. This is the ileum here. This is the cecum. And here will be the ileocecum. And I stay on the colon. I will go up again. I will see here the paracolic gutter. I will go to the hepatic flexure of the colon. I will follow the transverse colon here to the lienal flexure. And then I will follow the descending colon to visualize here the left paracolic gutter, and I continue up to the crossing with the left iliac vessels, which is there. And this is the point we have already seen using the transvaginal probe. And then to see the lymph nodes, we can start by the femoral vessels entering the lacuna vasorum of the inguinal ligament. So this is the femoral artery and the vein, and here passing the ramus ossis pubis, which is there. We call it external iliac artery and the external iliac vein. Here is the obturator fossa. Here is the shadows from the descending colon. Interiliac bifurcation, we are lucky that we have seen it before with the transvaginal probe because there is always the shadowing. And then we will follow the common iliac vessels. Here will be the aortic bifurcation. I will just show it to you here. This is the lumbar vertebra 4. This is the aortic bifurcation. And we will go up to the diaphragm. So this is the esophagus, liver, aorta, and here you have the anterior branches of the aorta, and the first is the celiac trunk. And I will just show you the celiac trunk because you are examining also the lymph nodes around them. So if we follow the celiac trunk, here is the bifurcation like the bird wings with the splenic artery running here dorsally to the alongside the pancreas. This is pancreas together with the vein. This is the vein. And you will see how the splenic vein is here confluenting with the mesenterial vein and coming in the hepatic hilum as a portal vein. But I will go here back to the celiac trunk. So this is the one of the branch is the splenic artery. Here is running, and then we have here gastrica sinistra, and then here this is the hepatic artery, common hepatic artery, which is then, nadechnem, nedýchá, if we will follow it, it will then here divide into the hepatoduodenal. Here it is hepatoduodenal and proper hepatic artery. So this is the proper hepatic artery of the celiac trunk. And the lower branch is the superior mesenteric artery. Here is just the left renal vein. This is the left renal vein. This is the superior mesenteric artery. And we always follow the mesenterial vessels just to be sure that they are not any visceral lymph nodes. So here we are in the mesentery. We have here the mesenterial vessels. And we would like to be sure that they are not any in the mesentery, any lymph nodes. She is, as I told you, very slim, so you don't have much fatty tissue, but you are here in the mesentery of the jejunal loops. And the same procedure is on the right. So we started by the femoral vessels, lacuna vasorum, external iliac artery, vein, obturator fossa. Here is the interiliac bifurcation of the vein and the artery. Here we will have the common iliac vessels. There will be the aortic bifurcation again that you see it, and we will go up, and you can of course also check the vessels in the transverse plane. So celiac trunk, superior is there mesenteric artery, and you can cava aorta also look for any lymph nodes, but you will have today patient with infiltrated lymph nodes. Here are not any lymph nodes around cava and aorta, and we should again go to the mesentery of the jejunal, of the ileal loops. So here we have the mesenterial vessels, and this is the mesentery of the ileal loops here. So this patient is healthy on doing the abdominal scan, and the lymph nodes of the groins I will show you tomorrow. And now if there will not be really questions, if yes, we will show it. If not, we have another example of transvaginal scan. So just if you have any questions, we are ready.
Okay, so there are no questions from our chat. I think no questions. We saw many interesting things in abdomen as well as pelvis, and Professor Cibula will have some comment or question.
Daniela, I just want to emphasize that ultrasound we use not only in oncogyne patients for the staging or diagnostic purposes of gyne disease, but also sometimes in complications after procedures, after surgeries. So you showed us the bowels. To what extent can you assess the bowels and in patients with a suspicious ileus and also some intraperitoneal processes like hematoma, abscesses, inflammatory changes?
Thank you, David. It's an excellent question. I will show some videos during my talk on ovarian cancer today, but the base is really to know the anatomy and the normal appearance of the bowel, and really to try to catch the bowel by each of your healthy patients, not only to look on the pathologies. So to learn the bowel in the pelvis, how it looks like, and the abdomen, to differentiate its small and large bowel, and to know how the wall is layered in the mucosa, submucosa, muscularis propria, serosa, and then it's much easier for you to evaluate the inflammatory disease like Crohn disease or colitis ulcerosa. So it's going step by step, and this dynamic aspect of ultrasound is really crucial, that by ELOs, sub-ELOs, we see the impairment of the bowel peristalsis. And I will have some clips during my talk today.
Because quite frequently I'm receiving patients after diagnostic procedure, patients who are referred to our department for a suspicious or for already diagnosed malignant disease, and you know, completely separately from our organs. You and others, Philip and others, describe diverticulitis or bowel inflammatory changes. So we really quite frequently send the patients to other specialists after your examination.
Yeah, that's absolutely true. Diverticulitis and diverticulosis is really frequent in our population in developed countries. So yes, and we should always make the surgeons aware about that, not to be surprised by some heavy adhesions process in the pelvis during surgery. So always remind your surgeons about any additional pathologies. So now, if you allow me, Philip, I just very quickly will show you one transvaginal scan, and you would like perhaps to introduce the patient. We will need just 5 minutes for that.
Okay, so now I can introduce the next patient. So during this live scan, during this session, we will see another patient. It's a 43 years old patient with no significant internal diseases, no previous abdominal surgery, who met her gynecologist because of pelvic pain from October 2022. So about one month of pelvic pain. During the gynecologic examination, no interesting findings: retroversion, flexion of the uterus, and some adnexal mass on the left side with local tenderness. The gynecologist took the blood to test the CA-125, which was elevated, as you can see, 500 international units per milliliter. Then other blood tests were added. CRP slightly elevated, normal blood count. And the patient was sent to our center. It was about 1 month ago. Daniela saw this patient and described the finding as inflammatory adnex tumor with the pyosalpinges on both sides. So pelvic inflammatory disease. The smear on PCR test for chlamydia was done, and it was positive. So the first ultrasound scan at our site was performed 15th of November, and now we can see the ultrasound scan of the pelvis after I would say 2 weeks of antibiotic treatment. It was doxycycline.
Yeah,
Daniela, are you prepared for the live scan?
Yeah.
Okay.
So I hope you have the screen already.
Yeah, we can see you clearly.
Perfect. So I insert the probe in the vagina again. The patient is using the contraceptive hormonal treatment, and here you see it's you can still slide the bladder against the uterus, which is anteverted, flected. Here we can move against the sigmoid colon, and the endometrium is nicely uniform and thin by the hormonal treatment. And now we will go to the right. So now we see the ovary. She's 43-year-old using the hormonal contraception, so you don't see the follicles. And here is the ovary, and here posteriorly to the ovary, you see here apex of the appendix, but it's really beautifully seen here. I will show you the structure. I stop it for a second. There is perhaps there is some content in the lumen of the appendix, but then you can beautifully visualize here the muscularis mucosae, muscularis mucosae, then submucosa is the echogenic structure, and hypoechoic muscularis propria. And even when she had really inflammation, there was still the normal appearance of the appendix, so I didn't expect it. It was the source. Only there was higher perfusion around the appendix in the serosa. So and the disease was bilateral, so more on the left side. So I didn't expect at that time that the appendix is the source of the pelvic inflammatory disease. So you can nicely see it, and here it's coming to the ileocecum. So this is the appendix there. Here is some like a little bit like the peritoneal pseudocyst. And this is the appendix, which you can find time to time in the pelvic location, very close. I will go back to the ovary. Here is the ovary, here is the appendix. This is what I wanted to show you. Regarding the tube is there. It's not dilated. There will be probably inside a little bit of still fluid, and you can visualize the wall. Here is the fluid inside, and the wall of the right tube is perhaps a little bit still edematous and a little bit more perfused, but it's not as it was. This is much better now. Here I continue to the right cornu and again back to follow the right tube here. So here is really effect of the treatment, and please note here, I wanted also to show you there by the ovary, there is a large lymph node here. And this lymph node is normal lymph node already. It was reactive lymph node before, but now you see the cortex, the medulla is not really hypertrophia of the cortex. And I will show you the longitudinal hilal vessels there, entering the hilum of the normal lymph node. So even though there is the lymph node, it has absolutely normal appearance. So this site is much better. And just not forget that you can find very close to the right ovary the appendix, and you can follow it here up to the cecum. So this is there, but we didn't expect that it was appendicitis, what was the reason. We really expected some sexual transmitted disease. And we move to the left side, and here, please, here again, you see here are the lymph nodes again. They are more reactive. Here there is the cortex much wider. I will show you also the vessel. This is the longitudinal hilal vessel. So this is reactive lymph node, absolutely not infiltrated, but reactive lymph node with the medulla, with the hyperplasia here of the cortex. And what about the ovary? The ovary has some functional cyst and the tube. I will go to the left corner, and I will follow the tube. And you see here the tube is still dilated. It has still edema of the mucosa. You see like cockwheel sign here still. This is some fluid inside. And I try to get for you some longitudinal section. So this is the wall. Here is the content, some fluid inside. And this is perhaps visible also here, and I will show you the perfusion. Here still are signs of some like subacute or subchronic changes of the left tube to me. So this is the left tube here. I just wanted to show you more of that. So this is the tube there around the left ovary. So that's what I wanted to show you, that we always, of course, any of you are receiving a lot of patients being sent for suspicious of ovarian cancer and you identify pelvic inflammatory disease. So here there were positive PCR showing the chlamydia infection and perhaps also some other mycoplasma, ureoplasma. She was treated with antibiotics, but we always make follow-up of these patients until the findings resolved, really that we are sure that not abscess is developed, etc. That's all what I wanted to show you here, Philip.
But we have several questions from our audience. So the first question regarding lymph node. Once again, we would like to see the screen from the examination room, screen of the ultrasound. Why do you think it's reactive or reactive lymph node, not infiltrated? Of course, we have the clinical situation in this patient, very, very unlikely. But could you please describe it for us and explain it again, why it's most likely only reactive?
Mm-hmm. Yeah, exactly. You must always have association with the clinical situation of the patient. So here I would say this lymph node is again oval, but here is the cortex, which is hypoechoic, is more wider. I have difficulties really recognize here the echogenic medulla, and also the vessels are like this, the longitudinal Heil vessel, and there is a branching. I try to identify it for you. This is the longitudinal Heil vessel with the branching to the germinal sinuses of the lymph node. So to me, the lymph node, you see, this is the situation how the normal lymph node should look like. But here still it's almost the cortex, the hyperplasia of the cortex. So this is the reactive and this is how it should look like. The normal lymph node with the wider medulla, with the thin symmetric cortex. And why it's not infiltrated by metastatic cancer cells? Exactly, this is because we know she has pelvic inflammatory disease. We didn't find anything suspicious, so we expect on the first place to be reactive due to inflammation.
Okay. I agree with you, of course. Another question. Regarding the left adnexale, do you describe it, or would you describe it as tubo-ovarian complex, or just Pio-Salpinx in this specific patient, left adnexale?
Now already as tubo-ovarian complex. By the last scan, I had almost difficulties to identify the ovary and the tube. It was really one mass. But now I also try whether I can move it. I cannot really move it against each other, but you see now you can really visualize the ovary, or at least the simple cyst, and here the tube. To me, it's now complex. I would not call it abscess. In abscess, I can tell only if I cannot recognize the structure of the both of tube and ovary.
Yes. And another question, it's about ureter. So, is there any diameter of the ureter which you consider to be pathologic, to be dilated, or would you worry about it? Was the normal ureter and abnormal ureter could look like?
I think that you usually find here the ureter, and you see it's clearly here normal. But if you are really wondering about any pathology, first, when we are really following the course of the ureter in the pelvis, we would do it if we would find the hydronephrosis. So if we would find the dilation of the pelvis of the kidney, then we will go back to the pelvis and search where is the we start always to follow the hydroureter from the kidney, and we go and follow the dilated ureter to find the place where is the obstruction. So if it's in the pelvis, we go up to the pelvis, then we take the transvaginal probe and we start here by the trigonum in the sagittal plane, and we follow the ureter in the pelvis. So I don't have any millimeter to say what's dilated or not. Just really you are looking on the normal findings which is there, or abnormal findings where you have the hydronephrosis, either the sinus or sinus plus callisis, or even the atrophy of the renal parenchyma.
Yeah, we can clearly tell there is peristalsis as another normal sign. So the thickness of the ureter changes dynamically according to peristalsis during the ureteric jet and so on. Okay, so no other questions regarding the pelvic examination in this patient. So we still have about 10 minutes for the discussion or for the abdominal scan, it depends. Professor Cibula.
Daniela, don't you want to join us here now so we can continue discussion?
Okay, I will be
here.
coming. I will be coming, so
yes,
I thank
please,
my patient.
Yes, please give our regards to both patients. You know, I know it's not very very pleasant, but it's very kind of them that they were used for the training purposes. Philip, one of the very attractive fields I find the ultrasound is really in the follow-up of patients after the surgery, in the diagnostics of complications, and ultrasound has really ability to describe dilated bowels, to describe fistulas, to describe leak at the site of anastomosis. Can you comment from your side how reliable you consider it is, and how you consider your ability to be involved in this in the diagnostics?
Yeah, of course. Can you hear me? Yeah. So ultrasound, of course, can be the bedside test for. Yeah, everything okay? Okay. So ultrasound can be the bedside test for the acute situations, of course. Then it can be used for the assessment of possible complications. We have experience with the recognition of lower rectum fistulas and lower bowel fistulas after surgery, with the application of physiological solution into the lumen of the bowel. I think that the data are not so large to have enough evidence that the diagnostic performance is the same as, for example, CT with contrast ergography or even MRI. However, I think that the ultrasound has promising results in this part. So it was regarding the complication and then
ileus.
And ileus. Yeah, of course, the gas inside the lumen is our enemy, severe enemy. So yeah, we can see the dilated in a loop, intestinal loop, or dilated bowel. However, the reason why it is without free fluid surrounding the bowel, it's difficult for ultrasound to localize the obstruction. I think that there is still the role for CT, but maybe Daniela will have other comments.
It really depends on the status of the ELOs. If it's at the start, it's much easier. If it's really chronic status, then it's more gas. But also sometimes you have the fluid inside and you can beautifully differentiate it whether they are ELO loops or jejunal loops. In the jejunal loops you have something like haustration, this like a valve inside. So it has different shape than the ELO loops. So it also helps us a little bit to look on the if there is inside the bowel, if there is a fluid, to discriminate which part it is, whether it's upper jejunal, lower jejunal, upper ELO or lower ELO part. So yeah, we try always to be of help.
Daniela, you showed us that size of inflammation, of inflammatory process in the pelvis, and you are sometimes in a difficult position because all three conditions can cause the symptoms and can be the reason why the patient is referred to our inflammation, endometriosis, and early tumor. So do you have some tricks or tips how to differentiate carcinomatosis from endometriosis and from inflammation?
Yeah, thank you very much. Sometimes it can be difficult if it doesn't suit to typical scenario. For instance, if I would have all the patient with some ovarian tumor and at the same time you have the signs of the chronic pelvic endometriosis she suffered in her fertile age, then it's more difficult. But still the ultrasound features are very typical. So we usually can differentiate it using the pattern recognition together with the clinical picture of the patient plus her age, her symptoms. But if we are uncertain and there is already signs either of the deep endometriosis or of the something like carcinomatosis, we can always do the true cut biopsy if there is no risk to puncture encapsulated mass. So in situation of doubt, we have this really help of getting histology very quickly. Yeah.
Philip, any further comments to this?
I agree in Daniela. In several situations, the problem-solving method is a true cut biopsy. Of course, there can be some group of features which correspond most likely with endometriosis, different group of features, not only one ultrasound feature, but many of them must be taken into account, which speaks for carcinomatosis and so on. I don't have so big experience with idiopathic colitis or other inflammatory diseases, but I think that in the majority of cases we can reliably distinguish between endometriosis and tumor spread carcinomatosis.
And pelvic inflammatory disease.
Of course, pelvic inflammatory disease as well.
Yeah, and we always follow up our patients. For instance, this patient, she was already a little bit out of the typical scenario. She was 43 years, married, one partner, and she was sent for suspicious of ovarian cancer. We expected it will be pelvic inflammatory disease, but it's usually in the adolescence, or it's related to diverticulitis or to appendicitis, but she didn't have any of that. So it was a little bit atypical, but then we saw the PCR results and it was then, of course, for us assuring that we are right.
Well, you mentioned the true cut biopsy, just to describe our routine, because as I said at the beginning, I cannot imagine as a clinician my role without ultrasound. So how the situation here at this department has been organized since 15 years. We have centralized office, outpatient office for patients who are referred to oncogyne indications one day on Wednesday. So we see usually between 20 and 30 patients, and all the patients are automatically first seen by clinician and then sent for ultrasound. And ultrasound is satisfactory imaging method in, I don't know, 85% of patients. So we don't need any more, you know, and the whole indications are done for the patient within 1 day. So the patient is seen by clinician, ultrasound back to clinician, then by nutritionist, anesthesiologist, internist, and psychologist. And the patient leaves the hospital with the diagnosis and with the plan for the surgery. And each week we do, I don't know, medium of 3?
3 to 5.
Yeah,
perhaps.
3 to 5 true-cut biopsies. So it's something we routinely use every week. And I really cannot imagine nowadays that I wouldn't have this available, because all these, you know, suspicion, unclear cases, or of course cases which are not a good cases for radical procedure, but we still will profit from the biopsy, or we need the biopsy to start oncological treatment. All of them are sent directly. We will talk about it at But this is how we are organized here.
Yeah.
Okay, so I can see there are no other comments or questions from chat. So now, as expected, we can have break for 15 minutes as it's scheduled. So we will meet here again at 2 o'clock.
Central European time.
Yes, sorry.
Okay, thank you.
So welcome back. I hope it was sufficiently long for you to have a bio break. And my introduction will be now from the clinical point of view. So what the clinicians expect from the imaging in ovarian cancer. So there are multiple situations, and in all of them ultrasound again plays a crucial role. And I will start with the screening. So you might be aware of this huge, it was one of the largest prospective trials ever conducted, if not the largest one, in gynae oncology, led by Ian Jacobs at that time. And they randomized more than 200,000 women who were postmenopausal, healthy, otherwise healthy women, and they were randomized into 3 groups, 1 control, 1 followed by ultrasound, and 1 followed by multimodal screening, ultrasound plus CA125, and they used a certain algorithm to not only consider the absolute level of CA125, but the trend in CA125. First data were published, interim results in 2016, and it looked quite optimistically because they showed a change of the stage. So obviously you see that in the control group there were 24% of ovarian cancers found in stage 1, 2, in early stage. In ultrasound the same, but in multimodal screening it was almost 40%. So it seemed that there is a trend towards so-called stage shift. But the final endpoint was mortality from ovarian cancer, and these data were finally published in 2021. You see that there was also certain stage shift apparent, but it was not translated into any change of mortality. Mortality on ovarian cancer was identical in all 3 groups. So, of course, we can criticize this study for many aspects, and this will happen with each and every study, because what is planned in 2000, in 2010, will be inevitably outdated, but still the evidence which we currently have is that we don't have screening. In other words, we don't have a reason to use either ultrasound or biomarkers in asymptomatic patients to detect ovarian cancers. Another situation is differential diagnosis, and it's completely different situations. So we already have symptomatic patient, or any suspicious finding in the pelvis was found by scanning, by any imaging modality which could be used for any reason. And here, and I'm sure Daniela and others will talk about it, that ultrasound and subjective criteria, so-called pattern recognition, seems to be the best currently available method for differential diagnostics, meaning for the differentiation between benign and malignant origin of the pelvic mass. Then we have another different situation, and this is that we have the patient with very high probability of ovarian cancer, and we want to manage the patient, and we have to decide whether this patient is a good candidate for primary cytoreductive surgery. Here, the the most reference probably study is from 2009, published by Andreas de Boer and German group AGO. They showed that complete cytoreduction, meaning that if the disease is in a stage that surgeon can remove the disease completely, these patients can profit from such surgery dramatically, and their survival is dramatically better. However, this study was a retrospective analysis of 3 prospective trials in ovarian cancer disease. So it was not a randomized study towards yes or no surgery based on the diagnostics. We also have nice data from, we can call it real-world evidence currently. One of them is a Danish database. It's a national database. So we can expect that all the cases are included in this study. And you see that median overall survival between the group with primary debulking and secondary interval debulking after neoadjuvant chemotherapy was not different amongst all patients, while in those in whom disease was completely cytoreduced to R0 was dramatically different, 37 months versus 56 months. So in current ASCO-ESMO guidelines, there is a recommendation that complete tumor resection at upfront debulking is the most important prognostic factor for patients with advanced ovarian cancer, and it's the main goal of the surgery. These guidelines were published in 2018. But you probably also are aware of the evidence, which is a little bit different. The EORTC study conducted in early years of this century showed no difference in progression-free and overall survival between those with primary debulking and neoadjuvant debulking. And the second study, which was conducted mostly in the UK and New Zealand, also showed no difference. So currently, the evidence is in fact against primary debulking, or rather saying that it doesn't matter whether we operate the patient upfront or after neoadjuvant chemotherapy. Currently, what's going on is the third trial, which should be a sort of definitive trial, which paid a lot of attention to the pre-selection of sites with a very good quality of radical surgery. The TRUST trial, led by German AGO, it has a very similar design as the previous CHORUS and EORTC study. So randomized patient into upfront and interval debulking surgery. And as far as I know, the first results are expected next year or in 2024. But still, there is a continuous debate. What's the role? I think that nobody questions the role of primary cytoreduction if a complete cytoreduction is possible. In current ASCO guidelines or ESMO guidelines is also written that when complete surgery with no macroscopic visible disease is feasible, then primary upfront debulking should be offered. So if I were to summarize the situation, we have no doubts that complete cytoreduction is important. And we have little doubt that the primary surgery is better than the interval debulking surgery after neoadjuvant chemotherapy. But the aim of current imaging is very important, to find the best candidates for the primary surgery. And as we learn, the best candidates are those patients in whom complete cytoreduction is feasible. So what are the signs of inoperability? This is also from ESGO-ESMO guidelines, and then later ESGO recommendations for surgery in ovarian cancer patients was published with slightly modified situation, with slightly modified recommendations, because the group recognized that some of those situations are actually operable, that even solitary metastasis in the brain, in the parenchymatous organs can be successfully removed and improve the survival of patients. So out of all the situations which are listed in the ESGO-ESMO recommendation, there is one which is the most important for our routine practice, and this is diffuse carcinomatosis of the small bowel. Otherwise, other situations are either very rare or potentially operable. So of course we have to consider the situation individually, and besides just the stage of the disease and extent of the disease, we also consider performance status, whether the patient is frail or not, the age of the patient, and we put everything into the context with the extent of the disease. Then another situation is selection of patients for secondary cytoreductive surgery. So let's say we have patient who was treated in the first line, and then we have the recurrence of the disease, and we need to decide whether yes or no to go for another surgery. Here the story more or less started with the retrospective cohort AGO study, which showed a dramatic improvement of the prognosis of the survival in patients in whom complete removal of tumor is achieved, and no difference whether there is left the disease of 1 centimeter, 8 centimeter, or 10 centimeters. But it was again retrospective study. So then 2 prospective studies were conducted, one by the GOG American group led by Rob Coleman, and they randomized the patient, and this was one of the reasons for the criticism twice. First for surgery, no surgery, and second for the type of systemic treatment. And the result was, surprisingly, that overall survival was even better in the group without surgery, and they did not find any subgroup who would profit from secondary cytoreductive surgery. But later on, another study led by German AGO was published with a similar, but I would say cleaner, more straightforward design, randomizing patients with recurrent ovarian cancer to either cytoreductive surgery or no surgery, followed by chemotherapy. Majority of patients with platinum-sensitive recurrence, and also the criteria or characteristics of the surgery was quite different from the American study, so this might be one of the reasons behind different outcomes. I will show you. It was really a radical surgery, medium time with more than 3 hours. 1/3 of patients underwent GI resection, and it was also, good quality of surgery was reflected in a very high macroscopic complete resection. And this is the outcome which showed significantly longer overall survival in the group after secondary cytoreductive surgery, although the difference was expected to be bigger. It was only 7.7 months in this study. Also PFS was different, but even smaller difference of 4.4 months. But the main, or one of the main messages is here, where they sub-analyze on a surgical group. They showed that there is a huge profit in those patients in whom the tumor was completely resected. So there is a very similar situation with primary cytoreductive surgery. Patients profit from the surgery if surgeons are able to completely remove the tumor from the peritoneal cavity. And this, of course, makes obvious requirement for ultrasound or for any imaging to tell the surgeons, clinicians, whether this case is a good candidate for the surgery. How we do it in our clinical routine, I can tell you that I receive after the ultrasound these patients, and I have, let's say, two clear groups. There is one which is considered by ultrasound clearly operable. In those patients, we go directly for the surgery. There is a group of patients in whom ultrasound describes like this is clearly inoperable. We can see signs of inoperability. There is a certain disease which cannot be removed, and these patients we send for true-cut biopsy, and we start with neoadjuvant chemo. And then there is a certain shadow zone where ultrasound say, there are some signs we are not certain. And in these patients, we usually start with diagnostics, laparoscopy, true-cut biopsy, and then we decide about make a final decision. Another situation is US-guided interventions. You will hear about it in a separate lecture, and you will also see several cases in live. And then the follow-up, just interestingly, because those of you who are from the younger generation might not be aware of this study, but this was very nice gutsy study. I like these designs, and they simply follow the patients after complete remission after the first line ovarian cancer patients. They repeatedly take CA-125 and randomize them into two groups. And in one group, clinicians receive the CA-125 results, and in the other group, they don't. So they were blinded to the results. And obviously what happened, not surprisingly, was that the group with known CA-125 levels were treated much earlier. And it's, on this graph, for me it was quite surprising to see that the time difference was quite profound. So there is a gap between CA-125 rise and the symptoms, which can be 6 or even 12 or 15 months. So it can be more than a year, but finally the survival was the same. So the message out of this study was clear. If we follow the patients intensively, we treat them earlier, we treat them more, they received more lines of chemotherapy, but the survival is the same. At the same time, we know from the study I showed you that patients can profit from secondary cytoreductive surgery if the tumor is completely removed. In other words, if I summarize everything, it makes sense to intensively follow patients in whom we think they are good candidates for secondary cytoreductive surgery. And in these patients, it makes sense. Otherwise, in other patients, it's better to leave them live their good quality life. So those are the situations, and in all of them, ultrasound may play a very fundamental role. As I said, ultrasound is the best imaging method, and here we have the data in a differential diagnosis of pelvic masses. And as Daniela will show you, we use as a first technique ultrasound also in the staging of ovarian cancer patients successfully, and only selectively, if we are uncertain, we send them for secondary imaging test. So that's it from my side, and I now the next will be the lecture from Daniela on ultrasound in ovarian cancer. Daniela, the mic is yours.
Thank you very much. So here it is. So now we will continue about the role of ultrasound in ovarian cancer staging. And first, today you have been already aware about the new guidelines. There are two important guidelines. The first is joint guidelines recommending the most effective approach how to differentiate it between benign and malignant tumor using the subjective assessment by an expert, and if no available is ultrasound examiner experienced, we should use the IOTA-based ultrasound models, and among them in Gynae-Oncological Center, IOTA ADNEX model is recommended because it helps us to differentiate it between malignant subgroups. I will show it later on. And the second, already mentioned by David, this year there are in preparation updated joint guidelines on recommendation of the useful modality for ovarian cancer staging. These all guidelines are about the management of ovarian cancer, and regarding the staging, all imaging modalities are recommended. It can be whole body contrast enhanced CT, MRI, PET-CT, but also ultrasound can be used to assess the staging and predict the resectability. And these guidelines will be published next year. The aim of ovarian cancer staging using any modality is first to confirm that the mass is malignant and that the origin is the primary tubo-ovarian cancer, not that there is metastasis from other non-genital primary. We should also pay attention on the tumor spread with special emphasis on the sites which are not easily accessible and could cause the residual disease left at the end of surgery. Preoperatively, we should also assess the tumor-related complications and guide through-cut biopsy in non-surgical candidates. So if we start by the diagnosis, for us, ultrasound, for all of us following the international guidelines, ultrasound is the first-line modality, while MRI can be used eventually as a second stage test in masses which are sonographically indeterminate. On ultrasound, it's clear, sonographically indeterminate. However, usually the MRI will just tell you whether the mass is benign or malignant, but the so-called sonohistology you will receive only from the expert. So now it's testing the role of MRI as a second stage test, but it seems that really the ultrasound is appropriate first-line modality, and MRI will not add us more information. ultrasound is for all of us method of choice because it is broadly available for all gynecologists, gyne-oncologists. It's cheaper than other imaging modalities. It's patient-friendly. It doesn't require any preparation, doesn't have contrast agent application, radiation load, doesn't have known contraindication. And also what's very useful, and you have seen it today, is the dynamic aspect. You observed really how the structures are moving, how looks the bowel loops. And we use also the biomarker to look on the perfusion, not only on the color score, but also on the vessel architecture using Doppler. And you will see it today. You will see metastatic tumors with clear different appearance of the vessel architecture. And these are the guidelines, the joint guidelines published on the diagnostics of ovarian tumor. So if there is incidental findings of ovarian mass, first of all should be performed ultrasound. If normal findings, patient can be discharged. If abnormal findings, then either expert or IOTA-ADNEX model should be recommended. And regarding the risk of malignancy, there will be further appropriate management. If there is intermediate or high risk of malignancy, the patient will be referred without any delay to gyne-oncological center. In the center, if there is no expert, we can again use IOTA-ADNEX model, but now certainly with CA125 to differentiate it which subgroup of malignant tumor is, whether it's early or advanced primary ovarian cancer, metastatic or borderline, because the treatment is completely different. And I would like to in the situation of which malignant tumor you will be expected. You can also as a second stage test other imaging modalities or true-cut biopsies or additional tumor markers. And now I would like to show you an example of 72-year-old lady. CA125 is not much elevated. She's after hysterectomy. And she was examined by her gynecologist. She didn't have much symptoms, just little bloating, and the gynecologist found this solid unilateral mass. But if you look more carefully, there is already some carcinomatosis. The mass is solid, well encapsulated, but irregular surface, and little bit acoustic shadows you can see, and ascites. If we look on the color, there is the ovarian pedicle, and you see that the vessels, like vessel tree, are branched within the ovary. So there is a moderate perfusion and this vessel tree pattern, which was described by Antonia Testa, being associated with eventually metastatic cancer. So if we will now apply the ADNEX or the IOTA recommendations, and today Wouter introduced you two-step procedure. So first you will start with the assessment of the ovarian tumor. It's not normal ovary. It's even not any simple unilocular cysts. The tumor is solid. So you really need in the second step, because the simple modified descriptors are not applicable, to use the ADNEX model. So we will go for ADNEX model in the hand of the referral gynecologist. He inserted the age of the patient. It is no oncological center. Size of the tumor, size of the solid component is the same. No locules, no papillations, but stripy shadowing, ascites, and he didn't or she didn't know yet the serum CA125. So now we led the calculation of the IOTA-ADNEX risk of malignancy above 50%, and the patient should be promptly referred to gyne-oncological center because she has the high risk of malignancy. Here, if there would not be expert, we will repeat the IOTA-ADNEX model, but with CA125, and she's already now in the center. There is higher prevalence of malignancy, so it must be also here clicked yes, and the level of CA125, and you will see it will not change too much. The risk of malignancy is still, it was still above the 60%, but the highest relative risk is for the metastatic cancer. And the joint guidelines, they recommend us now to eventually, because the risk is that it's a non-genital origin of the spread in the ovaries, to add other tumor markers or to add some whole body imaging to look where is the primary, or to take the biopsy, or do all these possibilities, markers, imaging, biopsies. So what we did, we made the expert ultrasound examination, and you saw it's a solid mass, so we expected eventually signet ring cell tumor, which can be from antrum of the stomach, appendix, breast, can be also breast adenocancer, lung adenocancer, melanoma, but of course we cannot exclude also primary tubo-ovarian cancer. The patient had already abdominopelvic implants, ascites, so the most effective approach was to take the TrueCut biopsy. So the TrueCut biopsy was taken during the same appointment. It's very efficient. We do it, we just ask the patient whether she does not use any anticoagulative drugs, whether she doesn't have any anticoagulative any disorders with the higher tendency of bleeding, and we take the biopsy, and the results is available in 48 hours. We did also whole body imaging, and you see the implants described on ultrasound, on mesentery and on diaphragm were found on whole body MRI, but nothing else, no primary origin. And we also added the tumor markers, and they were also not elevated regarding, for instance, the gastrointestinal tumor. And the slight elevation of CA15-3 is associated with the carcinomatosis and ascites. What was the TrueCut biopsy result? It was high-grade serous cancer. So we did the primary cytoreduction, and the patient was operated without residual disease. So this is how it is recommended, the approach by the joint guidelines. And now we move to the tumor spread assessment. And here we assess the spread in the pelvis using the high-resolution endovaginal probe, and in the abdomen using the abdominal convex array probe to assess the peritoneal spread, but also to assess the retroperitoneal lymph nodes, visceral lymph nodes, and also the thoracic lymph nodes. And with the linear array probe we can assess the groins and axilla and neck, head and neck lymph nodes, usually the scalene lymph nodes. So the main routes for the lymphatic spread in ovarian cancer is usually coming through here, through the ovarian vessels to the para-aortic level here, and from there usually around the anterior branches of the aorta to the visceral lymph nodes. The second route is through the ligamentum latum to the pelvic iliac lymph nodes, and the last is coming through the ligamentum rotundum on both sides to the groins. So these are the major, but then you can have also thoracoepigastric vessels spread from the groins to the axilla, or through the ductus thoracicus longus to the scalene lymph node. So if it is advanced disease, we assess all these locations. Which modality should we use? We can use whatever we like, because in the guidelines you can use any of imaging cross-sectional modalities. And if we just summarize the advantages and disadvantages, contrast-enhanced CT is very useful because of the rapid acquisition of the images. But it cannot detect small volume carcinomatosis, especially on bowel and its mesentery. PET-CT is usually not recommended in the primary ovarian cancer. We use it usually for recurrent disease before salvage surgery. In primary cancer, ovarian cancer, we use it as a problem-solving tool. In situation we have, for instance, some inconclusive findings in thorax, for instance in the lung, some small lesions on CT, then we add PET-CT, but as a second stage test. It also cannot detect small volume carcinomatosis because of the physiologic accumulation of FDG in the bowel. So in the bowel you cannot really see it properly, and also on the liver. Then is another modality which is whole body diffusion weighted MRI, which has two advantages. First, it can accurately characterize the primary tumor, and it can also detect the distant spread comparable to PET-CT. It has also, there is some evidence from Michelson, Catherine studies from Leuven, from Stefania Rizzo studies and others, that whole body diffusion weighted MRI can detect small volume carcinomatosis on bowel and its serosa, its mesentery. And I would like to document it on the images here from PET-CT, where there is the primary tumor, some tubo-ovarian cancer, and here is the implant on the bladder. And on whole body diffusion weighted MRI, you can visualize on the same patient another implants on the liver, here in the left paracolic gutter on descending colon, and here on sigmoid colon, plus the primary tubo-ovarian cancer and the bladder implant. So it seems as very promising methods, but it's still less available. It needs expertise. It has also cost and long scanning time, and there are still limited number of publications. What about ultrasound? It has an excellent resolution in the pelvis, so it's a method of choice to characterize adnexal tumor, to assess the carcinomatosis in the pelvis, but also to assess the peritoneal and lymph node spread with comparable results to contrast enhanced CT has been published, for instance, by Juan Luis Alcazar. But ultrasound also cannot detect small volume disease on bowel serosa and its mesentery. Therefore, we have initiated the study comparing ultrasound with the whole body diffusion weighted MRI using the same imaging protocol as in Leuven and with CT, which is the standard modality. And the only significant different results was in the assessment of carcinomatosis, where ultrasound and MRI were significantly better than CT. Otherwise, all three imaging modalities have similar results to assess the lymph nodes and to predict the non-resectability. And all three methods regarding the bowel serosa and its mesentery showed insufficient diagnostic performance. So in the same cohort of patients, we have learned in Isaac pilot study, that it does not exist any imaging modality capable to detect small volume carcinomatosis, so there is a potential role of diagnostic laparoscopy. In situation we are uncertain about resectability, and the role of imaging is to predict really the bulky nodules on the sites which are not easily resectable and select these patients for neoadjuvant chemo after the TrueCut biopsy confirmed gynecological origin. And now there was just now concluded the enrollment in the multicentric Isaac study, and we are expecting the results in the 2023, whether these promising results of ultrasound will be confirmed. So now if we look on the tumor spread assessment, we always assess the peritoneal spread in the pelvis, in the upper abdomen, on diaphragm, on the liver, on the spleen, on the lesser omentum, but also on the middle and lower omentum, on the mesentery, on the bowel, on the greater omentum. Then we systematically assess the lymph nodes, retroperitoneal, groins, visceral lymph nodes, and intraparenchymal metastasis. And we also, in some situation, assess also the thoracic lymph nodes, scalene, and axillary. So the parenchymal is here. So if we move first to the peritoneal spread, and I try here. So we start by the classification. So peritoneal carcinomatosis, this is peritoneal infiltration by any cancer. It doesn't need only to be related to ovarian cancer. It can be also caused by pancreatic cancer or by colon. But now we speak about the ovarian cancer. So the peritoneal spread caused by cancer cells is called carcinomatosis, and it's classified regarding the type of carcinomatosis of peritoneum involved. So it can be on the parietal peritoneum, in the pelvis anterior wall, pelvic side walls. Here it can be in the paracolic gutter in abdomen, on diaphragm. Then it's called visceral carcinomatosis, whether the carcinomatosis on the viscera, in the pelvis, on the uterus, on the bowel, on the bladder, and in abdomen, and in abdomen on the, I try to go back now, on the liver or other parenchymal organs and visceral organs, and on the bowel. And then it's called mesenterial carcinomatosis if it's infiltration of the mesorectum, sigmoid, mesocolon, in abdomen, mesoappendix, root of the small mesentery, of the small bowel mesentery, then transverse mesocolon, sigmoid mesocolon. And you should not forget that the omental carcinomatosis is also included in the peritoneal spread. In the lesser omentum, which is the hepatoduodenal, hepatogastric ligament, and the greater omentum, which is divided into supracolic part in relation to the transverse colon and infracolic part. Ultrasound appearance differs between low-grade serous cancer and high-grade cancers. In low-grade serous cancer, there is a lot of psammoma body, so within the ovary, the solid portion is very echogenic, and also the carcinomatosis is markedly echogenic. It's really almost white. It looks like a gas in the bowel or like the fatty tissue. So be really be aware about that here this is the carcinomatosis, which is very, very like stone-like, very hard, and it's here filled all the pelvis and also infiltrating both ovaries. So this is the left ovary, and you see also within the ovary the echogenic portion. So this is low-grade serous cancer. In high-grade cancer, not only high-grade serous, but also in high-grade endometrioid and other high-grade type of cancers, you find usually hypo or isoechoic solid component, and the carcinomatosis is usually iso or hypoechoic. And there will be the video now running. So here you have the carcinomatosis in the mesorectum, on the parietal wall of the pelvis is hypoechoic. It's growing in the mesorectum, but will be also not only on the parietal side wall, but we will find it on the epiploics here, on the fatty epiploics. Also on the visceral surface of the bowel is the hypoechoic carcinomatosis. And there is in the same patient also intraparenchymal lesion in the spleen. And you will find also not only dilation of the kidney, but also here large carcinomatosis on the liver. And we use the standardized terms to describe the carcinomatosis, parietal, visceral, mesenterial. Either we have just the nodule visible, or if they are merged together, we call it diffuse-like or plaque-like carcinomatosis. In omentum, you can have again just nodule, and if they are merged together, you find like very rigid plate. We call it omental cake. Then we should also tell the surgeon whether there is the carcinomatosis on the bowel just infiltrating serosa, which is superficial, or if it's already infiltrating the muscle layer and deeper, because there will be the resection needed. And here usually just the peritonectomy. And on the viscera, again, whether it's only on the capsule or whether the carcinomatosis is deeply infiltrating the parenchyma. And in differential diagnosis, we have hematogenous spread when the nodules are within the liver or splenic parenchyma, and there is always the free tissue between the tumor and the capsule. And now I will show you some examples of the nodules, nodular carcinomatosis, and the plaque-like here. So we start here by the carcinomatosis in the pelvis. So here there is a nodule in the pouch of Douglas. The patient is not treated yet, so it's highly vascularized, and this is a nodular carcinomatosis. Here is already the plaque-like carcinomatosis confluenting together. Now, in the omentum here, you have the nodular carcinomatosis, and in the pelvis I mean below the transverse colon towards the pelvis, you will find the rigid plate, which is called diffuse omental infiltration. So we will move now to the omentum. So we start between the stomach, the greater curvature, and the transverse colon to look on the supracolic omentum, and here is some nodules, which is the sign of the nodular infiltration. And today you will see some of these examples on live scan. Then we continue here over the transverse colon towards the pelvis, and here you can already identify this rigid plate, which is diffuse omental infiltration. So here there is an omental cake. Now we will look on the superficial bowel infiltration where the muscle layer is still preserved, and here you cannot already visualize the hypoechoic muscle layer. So we start here first looking on the superficial carcinomatosis, diffuse carcinomatosis on the bowel, but still you can identify the hypoechogenic muscle layer. So this is the hypoechoic carcinomatosis here. And then we will see the example. This is still the superficial on MRI. You see such a nice resolution we have on ultrasound. It's really beautiful. And here we are on the deep infiltration. So you will not be able to recognize the hypoechoic muscle layer in all directions. It's already infiltrated. And lastly, about the superficial implants on the spleen, they are on the capsule, and here will be a deep implant infiltrating deeply liver parenchyma. So we start here. First we will be in the left hypochondrium, and here is some small nodular implant on the capsule of the spleen, and you will be also here visualize the implant there on the, here it is, on the spleen surface. Anyhow, the patient will undergo in that situation splenectomy, and here is a deep nodule deeply infiltrating the liver parenchyma. There are multiple here. About the lymph node involvement, we first classify the lymph node as peripheral, and these lymph nodes are beautifully visualized on ultrasound using the linear array probe. Head and neck, scalene lymph node, axilla or groins, and tomorrow you will also hear beautiful lecture of Georgia Garganes. And then non-peripheral, as I taught you, we have the retroperitoneal, iliac, para-aortic. Then we are observing the lymph nodes around the visceral branches, around the celiac trunk, called celiac visceral lymph nodes, around the mesenterial vessels, called visceral mesenteric lymph nodes. Can be also visceral lymph nodes in the pelvis, of course, for instance, paracervical lymph nodes. And then we have in the anterior thoracic lymph nodes, this is usually related to massive diaphragmatic infiltration, where through the lymphatic anastomosis there is spread to the cardiophrenic lymph nodes, and then we have the others. So now I will show you example of the infiltrated lymph nodes in the groin, in the left obturator fossa, and interaortocaval. So we start on video in the left groin, and we will first visualize the vessels, which is the femoral artery, here was the saphenofemoral junction and the femoral vein. Here is completely infiltrated rounded lymph node, and here is a normal lymph node with the cortex, with the medulla next to the infiltrated lymph node. Here are transcapsular vessels, and here are normal longitudinal hilar vessels. We are in the groin. Now we have the transvaginal probe, and we can identify 2 lymph nodes with the loss of the normal architecture. You cannot identify here the medulla, the cortex. They are matted together just with the transcapsular vessels, and you can very nicely differentiate their architecture. But if you would use only the abdominal probe, this is the same patient, there is the shadow from the sigmoid colon, and probably you will not be able to recognize them clearly. So always please combine the transvaginal scan with the transabdominal scan. And now we move to in the sagittal view between the cava and aorta, and you see here many lymph nodes which are here between the aorta and the cava in the sagittal plane. And we will turn the probe 90 degrees counterclockwise. You will first recognize here the aorta, here the cava, and here are the infiltrated lymph nodes between them. And regarding just example of the lymph nodes in the hepatic hilum, which are visceral celiac lymph nodes, here we will identify the portal vein, and you have infiltrated lymph nodes behind and ventral to portal vein. So here ventral the portal vein, and behind here you have the infiltrated lymph node, here and there. How can we differentiate the infiltrated lymph node? We have either the partial infiltration, where still you can recognize the part of residual lymph node with the cortex, with the medulla, with the normal vessels entering and leaving the lymph node, which are called longitudinal hilar vessels. And in the partial infiltration, you have here the intranodal metastasis. In some situation, there is a rupture of the capsule, and already the pathologic neovascular transcapsular vessels. Or you cannot find any residuum of the lymph node. The lymph node is completely replaced by cancer cells, rounded, hypoechoic, and with the transcapsular pathologic vessels. And here is the example. So here it's very difficult with the pointer. Here you can see the residuum of the lymph node, and there is the intranodal metastatic lesion with the capsular interruption. And here this is already completely infiltrated lymph node with the hyperechoic ring around and with the transcapsular vessels. So this is a situation of complete infiltration. And we use the standardized terms, definitions, and measurements to describe the lymph node. It was originally developed by Vita Group, which is a group of experts involved in the treatment of vulva cancer patients, and we find consensus how to describe the lymph nodes in vulva cancer, and you can find also the video summarizing the content of Vita article, which is for free available, published in 2021. But it's very important to know that these proposed terms can be used to describe any lymph node in the human body if the lymph node can be clearly visualized. So we used these terms for description of any lymph nodes, not only for inguinofemoral lymph nodes. Tomorrow we will talk about that. And lastly, intraparenchymal metastasis as a part of staging. You already know that these lesions must be located deeply in the parenchyma, and there is always the free tissue between the lesion and the capsule. And I would like to show you the video. So now there is a subcapsular metastasis which is growing from outside inside, and here this is the intraparenchymal. So subcapsular lesion first is visible there, and here is the intraparenchymal hematogenous lesion, and you have it here as well. So deeply infiltrating subcapsular peritoneal metastasis, and then here is the intraparenchymal hematogenous lesion. We should also always inform the clinicians whether the tumor is not located on sites which are not easily resectable and may lead to residual disease at the end of surgery. And I would like to show you the most frequent reason for suboptimal surgical results, and this is diffuse carcinomatosis on the small iliac lobes in a patient presenting with this large tumor. And here you will see first the uterus and then the small intestinal lobes. Usually these are in the pelvis, the iliac lobes, and you see diffuse carcinomatosis on the surface, but still the lobes are not dilated and there is still absolutely normal peristalsis. And you can nicely use the dynamic aspect that you can ask at the same moment the patient about the complaints. You look on the bowel peristalsis, you look on the diameter of the lobes. And just to show you the markers of non-resectability which were summarized by the ESMO consensus 2019 and will not be changed in the updated consensus 2023, the most frequent is probably the small intestinal carcinomatosis, the reason of non-resectability, plus the infiltration of the mesentery of the small intestine. Then the diffuse carcinomatosis on the stomach, duodenum, pancreas, multiple liver metastasis, infiltration of the hepatic hilum, or other non-resectable lymph nodes, usually multiple lymph nodes in the mesentery. We have tested this ESGO criteria in our multicentric ISAC study, and in the interim analysis we have shown that ultrasound was non-inferior to CT and MRI to predict non-resectability, and that ESGO criteria are very easy to be applied, and we don't need any very complicated scoring system as, for instance, peritoneal cancer index and other systems. We can just really look on these criteria. However, the decision whether we will do the upfront surgery or interval debulking surgery does not depend only on the resectability which is visualized on using imaging, but also on the quality of the center, and the quality indicators were published, and on the patient status, whether the patient can tolerate multiple resections. So it is always multidisciplinary team decision. And what about the preoperative diagnosis of tumor-related complications? Sometimes in clear cell cancers, for instance, which are very infiltrative cancers growing in the pelvic side wall, you can find hydronephrosis. In some situation, you can find deep thrombus here in the femoral vein on ultrasound, and you can also find the impairment of the bowel peristalsis. You see the peristalsis is not effective, is coming forward and back, not really effectively propulsive. There is a diffuse carcinomatosis, the loop is dilated, and at the end you can find this is the stomach dilated with the fluid, and you will find the bowel loops which are filled by the fluid, and this is called malignant bowel obstruction syndrome. And lastly, if you have the candidates which are not optimal candidates for surgery, or you have suspicious of secondary ovarian tumor, there is the possibility to use ultrasound to guide the true-cut biopsy. And today there will be 3 true-cut biopsies during the live transmission. So, and Philip will have a nice lecture about it. So, at the end of your systematic examination, you write your report, you describe the FIGO stage, but also you will write to surgeon whether there are sites which are non-resectable involved by cancer. If you are uncertain about the resectability, you have some indirect sign of possible non-resectability, you can advise the surgeon whether she should start with diagnostic laparoscopy first and then continue with laparotomy. If there is suspicious of secondary ovarian cancer, at the same appointment you provide the ultrasound guided true-cut biopsy. You recommend the other cross-sectional test, other tumor markers. It is not automatically recommended by the surgeon, but by the ultrasound expert regarding the findings. So to conclude, ultrasound is the first-line modality to assess the ovarian tumor and also the pelvic spread. Inexperienced hands can be effective alternative to do the staging in abdominal cavity. So we can use ultrasound for staging and prediction of non-resectability. All imaging tests cannot detect small volume carcinomatosis, especially on bowel serosa and its mesentery. However, the role of imaging is to detect the bulky disease on sites which are not easily resectable and to select the patient for neoadjuvant chemo after the TrueCut biopsy confirms primary ovarian cancer. And ultrasound-guided TrueCut biopsy is a very effective approach to provide us histological diagnosis. So this is all from my side, and now you will tell us what's the next.
Okay, so the next step in our scheduled program is a live scan. So we are delighted to see the lecture in practice. So there are no questions from the chat. So we can proceed to the live scanning. We will see 2 patients with advanced disease in pelvis and abdomen. The first one is considered to have the primary ovarian cancer. However, we still do not have the histologic verification. She is waiting for the surgery. It's a 60 years old patient with negative family history regarding any malignancy. It's a postmenopausal woman with the history of 2 vaginal deliveries, no gynecologic procedures, no abdominal surgery. She has no internal diseases and no chronic medication. She has minimal gastrointestinal symptoms, namely bloating, and there is incidental adnexal mass which was revealed by her gynecologist on ultrasound scan. Then after the examination, the blood test for CA-125 was performed with elevated level 741. This patient was referred to our center, where she underwent gynecologic examination with no specific pathologic findings. Ultrasound, we will see it for today once again, and she has CT scan. And according to description of the original CT scan, there were ovarian tumors and omental cake. However, in this case, as in the others, we want to have second reading because there were some discordance between ultrasound finding and the CT. So we asked our radiologist to describe the CT scan once again, and you will hear the second reading description of the CT for now. So there is other dissemination which was described by our more experienced radiologist, and it's my pleasure to invite here our collaborator from radiology department. It's Professor Burgetova, who is here for us to describe the CT of this patient once again for you. So you will see it, and now I can pass the phone to our guest. the lecture the other images from this PowerPoint application. Thanks.
Thank you for invitation and for introducing me. And I'm here to show you some images, some pictures, what I prepared for you for this patient. So I described yeah, thank you. I described subtle carcinomatosis on the right diaphragm here, some nodule in the supracholic omentum here. The other slide, please. The other picture. Oh, I can, yeah. So then nodules in the infracholic omentum here and here. This is dense infiltration of infracholic omentum, so-called omental cake. And this is the omental cake in the sagittal plane, in the sagittal reconstruction. Here you can see the tumor mass in the adnexal region. Then retroperitoneal lymph nodes. Here you can see the lymph node, infiltrated lymph node suprarenal. Here is the renal artery, right renal artery, aorta and vena cava, and here is the infiltrated lymph node, and here is another lymph node, precaval. So this is also infiltrated lymph node. Here you can see the retroperitoneal lymph node in the coronal plane. Here this is the lymph node, and here this is the mass in the right and left adnexal region. And adnexal mass again in the axial plane. This is multilocular solid mass, right and left. And here you can see infiltration of mesocolon, mesocolic infiltration, mesosigmoideum and mesorectum infiltration, and the deep infiltration of the rectal wall here. And it is, you can see that it is all together, so we can describe it as a frozen pelvis.
Okay, thank you, Andrea. So we can see that it's really there is a really advanced disease. Now we can compare the CT scan with the ultrasound scan. I think that the patient is already prepared in the examination room. So I hope that we can hear you, Daniela. Am I correct? Yes. So you are prepared. We saw the CT scan, and now we know that it's advanced disease. We have to assess the resectability. Okay, so if you are prepared, then we can start.
We are prepared.
We can start with the transvaginal and transabdominal scan in this patient.
Philip, do you have our screen, our ultrasound screen?
Not yet. I think that it will be in few seconds. Yes, now we can see the ultrasound screen.
Exactly. Yes. Perfect. Thank you. So I start first. I will insert the probe in the vagina in my patient, which she was introduced now by you and Andrea. I have here the uterus is anteverted flected, And this is a postmenopausal patient. So here is the external cervical os, endocervical canal, thin endometrium, and a little bit of the hypoechogenic fluidometra. But here is already not good mobility against the bladder. We will check why it is, whether there is not any carcinomatosis. It seems here can be probably fixed to very superficial carcinomatosis, which is not really thick, it's not visible, but you see that the uterus really does not move. And then we will go dorsally around the uterus, here to the rectovaginal septum and to the bowel, and we will check how the uterus is mobile there. Here against the rectum, it's still movable, but here is the uterus, sorry, that you see it. Here you cannot already move it. So here is a complete obliteration of the pouch of Douglas because of the carcinomatosis there, with infiltration also of the bowel. And there is also the ovarian tumors, which I will show you after that. But the reason why there is the obliteration is the carcinomatosis. It's completely obliterated. You cannot see any free fluid even there. And the infiltration is up to here. The internal is like the internal part of the cervix, on the level of the internal os of the cervix. Here probably we would expect the parametria infiltrated, and this is the hypoechoic carcinomatosis, and we will try to follow the carcinomatosis on the surface of the sigmoid colon. You see there is a hypoechoic carcinomatosis deeply infiltrating the muscle layer, which you can beautifully see here. Here is resolved by the cancer. And then if we will go on the bowel, I go now. I am in the close proximity of the left ovarian tumor. Here the rectum seems a little bit better, but I am afraid that the complete resection of the sigmoid colon will be needed because it's really very deeply infiltrated. And here by the rectum there is a normal finding, so the anastomosis here will be possible between the terminal part of the rectum and the upper part of the sigmoid colon and remove the infiltrated part. Now we will look on the ovaries here. You have seen by CT already. Here is some part which we were uncertain whether it cannot be the tuba cancer here, the mass, because it seems a little bit that it's isolated from the ovarian mass, and it has really like some septa, pseudosepta, solid content, and we were eventually here expecting it can be tuba cancer, but of course we do not have the biopsy yet because we will do the primary surgery probably. And here is the ovarian tumor, which can be caused by infiltration from the tuba cancer eventually. So this is a multilocular solid tumor with the solid component like here. This is the solid component there. We can also look on the perfusion whether will be possible CAL score 3. And you see, sorry, excuse me, I removed the color. And you see also the septa are a little bit irregular. Here is the irregular lumen of the cysts. So this is the multilocular solid tumor with the cystic fluid, which is of low level echogenicity, and certainly it is a malignant tubo-ovarian tumor there, but I cannot tell you whether it's really primary or metastatic. Of course, can be also metastatic certainly from tube in the ovary or from other region here in the pelvis. For instance, here if it would be sigmoid colon, can cause the metastatic infiltration. So it will be decided by also by the multidisciplinary team whether the true cut biopsy will be needed before the surgery. But regarding the imaging and CT, it seems more likely to be primary ovarian cancer. So it's fixed here, but it does not infiltrate the pelvic side wall. This is the right side. I will go to the left, but I just wanted to show you here the iliac vessels. So here we have the internal iliac. And then I wanted also to show you the external iliac vessels, if it's possible. They are here. So I have here the external iliac artery and the vein, and the internal iliac, and here is no para-iliac lymph nodes present. They are para-aortic, but probably not iliac. We move to the left side. On the left, you have again here ovarian mass. It is a multilocular solid tumor. The echogenicity of the cystic fluid is of low level echogenicity. The number of locules can be more than 10, and the solid component, this is difficult, but I would say, I just searching here. So the solid component, the largest portion can be, for instance, measured there. So this is again, so this is bilateral malignant ovarian, tubo-ovarian tumor with the carcinomatosis on the bowel. Again, I will show you here with the complete obliteration of the pouch of Douglas, of the wall of the bowel. And there is a carcinomatosis also in the pouch of Douglas. And we have seen that the parametria are infiltrated, dorsal parametria.
Okay,
in the anterior
can I interrupt you for a while? We
Yes,
have some
please.
questions from the chat. So,
please.
do you have any tips and tricks how to differentiate the primary ovarian from advanced gastrointestinal cancer, colorectal cancer? Of course, we can use the tumor markers, the ratio of CA125, CA99, but ultrasound features. How to
Yes,
differentiate primary ovarian and primary gastrointestinal?
Yeah, it's very important to try to identify whether the tumor, if it would be colorectal cancer, whether it's from mucosa. And here it seems it's from outside. Because here is the mucosa, muscularis mucosa, submucosa, and muscularis propria is infiltrated. So this is the first that I really didn't see tumor coming in the lumen, in the mucosa. Second, why probably it's primary ovarian. I usually find if there would be such a large, because it would be then really long infiltration eventually, if it would be, and it is not, probably sigmoid cancer, I would, by this spread, I would expect already a lot of visceral infiltrated lymph nodes around. You can really find again around the colon, lot of infiltrated lymph nodes which are not here. So this is the second eventually sign which is more likely that it will be carcinomatosis related to ovarian cancer. Also, the echogenicity can be helpful, but in colorectal cancer, there will be probably also this infiltration will be hypoechoic, but if there would be carcinomatosis, you find something like pseudomyxoma peritonei, more mucinous ascites, which is not here. So yeah, so to me, probably more likely will be ovarian tumor, but it's very difficult here. Yeah, that the tumor is not originating from the mucosa of the colon, there is not visceral lymph nodes present, no mucinous ascites like pseudomyxoma peritonei. On the other hand, if there would be infiltration of the ovaries from colorectal cancer, it could be of this appearance, like multilocular solid tumors. So you see, it's really not easy. And that's my reply, yeah.
Okay, thank you. And just a general question, could you just illustrate how to systematically assess the pelvis? There is just question, do we have any module how to assess the anatomy on ultrasound, just briefly in this patient?
Yeah. So first, you usually examine the gynecological organs. So the position of the uterus, the mobility here, it's really fixed to anterior compartment, fixed to posterior compartment. We have seen that here is complete obliteration. I cannot move it. There is complete obliteration of the posterior compartment, including the posterior ligaments, parametria. Then we are, of course, focusing on the cervix, on the endometrium, on the layers of the myometrium, on the serosa. Here is infiltration of the ligaments. We talk dorsal parametria. Then we go to visualize the tubo-ovarian structures on the right. Here is this solid portion which we are uncertain whether it cannot be related to tuba cancer there. Here, and then here is a ovary which is completely infiltrated. It is a malignant lesion, and again it's very fixed. We go to the opposite side to visualize the left side. Here again there is the infiltration of the ovary and perhaps also of the tube. I really cannot tell you here whether it's not a dilated tube here and here the infiltrated ovary, but certainly there is malignant infiltration. Then we move to follow to examine the posterior compartment by rectovaginal septum, pouch of Douglas. We know there is infiltration, there is carcinomatosis. I will demonstrate it here with the infiltration of the dorsal parametria, and we go really on the not only anterior aspect of the bowel. I always also look on the posterior side between the bowel and the sacral bone whether there is not mesenterial carcinomatosis, and I follow the bowel up to the crossing with the left iliac vessels. The same anteriorly. Here is a fixed tumor to the vesicouterine plica. One ureter, this was the right, left ureter is there. And lastly, I always move the pelvic side wall and I examine the internal iliac vessels. Here they are. And the external iliac, here they are. And I look whether there are not any infiltrated lymph nodes. Then we move to the opposite side, and again we will have the internal iliac vessels. And here will be the bifurcation with the external iliac. So these are the external and the internal iliac, and no infiltrated lymph nodes. And then I move to the abdomen. So you see here is really complete obliteration, no ascites, malignant tubo-ovarian infiltration, carcinomatosis, infiltration of the rectum, sigmoid colon, modified posterior exen surgery will be needed. Can we go to abdomen?
Yes, I think so. Yeah. So you predict the necessary resection of rectosigmoid, but no signs of non-resecability in pelvis. So we have to look at the abdomen.
Romanko, přikryj mi paní tam někde. Tady. Dajte nožičky. Tak. Bezvadně. So now we will be ready. So in the abdomen, I will go here quickly. I ask the patient first to take a deep breath, and I start in the left hypochondrium. As you can see, here is the spleen. Posterior to the spleen is the left kidney. There is no ascites. And this is the stomach and the gastrosplenic ligament. Then you have here the hepatorenale, and also here should be the cardiophrenic ligament. There is no signs of infiltration on ultrasound really. And then I will move here to the right side. And this is the right kidney, so there is no dilation of the kidneys. And we will continue. Here is the duodenum, gallbladder. Then I have here the already the upper part of the duodenum, the stomach, and here again when I go back, this is the stomach, and here you see.
I'm sorry to interrupt you, Daniela. Is it possible to have more light in examination room, slightly more, because it's really very.
We try.
Now it's perfect. Thanks.
Yeah. Thanks. So here again you have the stomach there, and I ask the patient to take a deep breath, and here I will have the duodenal bulb around the pancreas. This is the pancreas there. It's a little bit atrophic. This is the pylorus, and this is the duodenal bulb. This is the antrum. There is no infiltration visible, and I will look. And I will look now to the liver. I follow here the hepatic veins. They are fatty liver, because if you see the kidney parenchyma echogenicity and the liver, it's a little bit more echogenic, but here, for instance, is already some hyperechoic focal changes. So she has some focal fatty liver. And while examining the parenchyma, we also look on the surface, which is a little bit irregular, but to be sure whether there is carcinomatosis, I would need probably more fluid, which is not present. This is the echogenicity related probably to fatty liver, and I don't see any infiltration of the liver. This is the duodenum, this is the pylorus, and here is the hepatic hilum without infiltration. There is no infiltration of the lesser omentum, of the hepatoduodenal and of the hepatogastric part, and we move now to the greater omentum. This is the transverse colon, this is the stomach, so here will be the little bit thickened supracolic omentum. And if we will go now over the transverse colon, I try again to show you the transverse colon. This is there. So if we will cross it towards the pelvis, here are already nodules within the omentum. I try to show it again. They are nicely contrasting with the fatty tissue here again, with the fatty tissue of the omentum. You see here the nodule really changes in the infracolic part of the omentum. And then here are already these ovarian tumors. I will move to the right paracolic gutter, but I think there was everything fine. So I follow the ascending colon here to the ileocecum. It seems fine. I will stay on the colon and I will go to the transverse colon, to the Liena flexure. I have here the jejunal lobes. If you cannot find here which is there, the descending colon, I always go to the place where we know that the colon will be crossing the iliac vessels. And from there, you can again go in the left paracolic gutter up to look whether there is not any infiltration of the descending colon. I go again down to the crossing with the iliac vessels. And then femoral vessels, lacuna vasorum, external iliac, common iliac, and now will be the bifurcation of the aorta. And here already you see the lymph node. So this is the interaortocaval located lymph node, which is just above the bifurcation, is rounded, hypoechoic, in the short axis about 8 millimeter, and we will continue up. There will be probably some other lymph nodes. We will check them, and we go to the diaphragm. And I am wondering how it looks, the mesentery. So I will just now follow the mesenterial vessels to the mesentery of the jejunum. Here are not really large I don't see any large implants. These are the jejunal loops. This is fine. And the opposite side, femoral vessels, lacuna vasorum, external iliac, common iliac, aortic bifurcation. And we will go up. And now I will go to the transverse view. So just now, we will be looking whether they are not infiltrated lymph node. Here is one. This is here is the celiac trunk. So it's between the celiac trunk and the superior mesenteric artery. Interaortic valve was one lymph node. I just wanted to show it again. Nadechněte. And other lymph nodes are below. Here, this is the lymph node, we know about it already. And then here is the bifurcation.
mass, lymphatic mass, pretracheal, and then a little lower, this lymphatic mass in the tracheal bifurcation surrounding the right main bronchus. So it's bulky mediastinal disease. Then you can see the nodule in the lung, so lung metastasis, and this is bulky lung metastasis infiltrating mediastinum. This is a lung window, and you can see the same metastasis in the mediastinal window. Here you can see implants in the breast. Here is a subdiaphragmatic region, and you can see again the retroperitoneal infiltrating mass surrounding aorta and truncus celiacus, and infiltrating left adrenal glands. So it's bulky mass, and this mass causes also the thrombosis in the left renal vein. So it is tumor thrombus in the left renal vein. You can see the differentiation between contrast in right and left kidney, and this is the large kidney cyst. It is benign finding. Then you can see dilatation of the left urinary tract, dilatation in the cardiopulvic system, and dilated ureter. And this dilated ureter you can see to the iliac bifurcation, and into the iliac bifurcation extends the mass of the ovary. This is here. And then ovarian tumor, mostly solid tumor, left and right. And if it is a primary ovarian tumor or metastatic tumor, it's a really question, how said Daniela, and I can confirm it.
And what's your expert opinion about this ovarian mass?
I think this is metastatic.
Yes, I think so.
But we will see.
Of course, we will see these ovarian lesions now during the live scan. So many thanks, Andrea. And we will see the live scan of this patient. I think that we will see even the TrueCut biopsy because. In fact, it's a one-step procedure to have the initial scan, and immediately after the completion of this initial scan, we can do the TrueCut biopsy to verify our diagnosis. So you will see our daily routine. It's from our clinical practice. So Daniela, are you prepared, and can we start?
We are ready.
Yeah.
Do you see our ultrasound?
Now we can see the screen.
Perfect.
Okay.
Okay, thank you. So I will insert the probe again here in the vagina. So here, excuse me, I wanted to show you the cervix carefully. Here is the external cervical os, endocervical canal, endometrium, and the uterus is again fixed here to the anterior compartment by very thin here carcinomatosis. So here is some carcinomatosis of the vesicouterine plica. You see it here. And then I wanted to show you the ovarian tumors, and we will go first to the right. you know that the metastatic disease from breast cancer is usually solid, usually around 5 centimeters solid lesion. And more typical looks on the left side. Here really I have impression, I see the hematogenous subcapsular nodes, which are the hematogenous metastasis there of the breast cancer. So my impression on the left side looks really very likely to be multiple hematogenous subcapsular metastasis. And if I will use here the color Doppler, usually you found around this lesion the like ring-shaped vessels. So you find here like ring-shaped vessels around these hypoechoic lesions. But of course, we need to do the true cut biopsy from the ovarians, from the solid portion of the ovarian mass. This is the right side where there are more locules than I would expect it, but still the structure of the solid component here could be eventually the small metastatic nodules inside. So here we have bilateral ovarian infiltration, and we are worried it will be more likely to be related to the breast cancer. And I would like to show you very quickly abdomen, and then we continue with TrueCut. If you don't mind, I would like to show you fast abdomen. Is it possible?
Yeah, I think it's possible.
Perfect. So I take the convex array probe in my patient and natáhneme nožičky, Románko, přikryj mi ji, prosím tě. And you will have again the possibility to natáhněte nožičky, to see also the external. Do you see the external camera?
Not
again?
Yet. Not yet.
And
we're still
now,
waiting for the yeah, now we can see it.
So I ask the patient to take a deep breath. So here, nadechnout a nevydechovat, jo?
So now we can have the correlation with the CT scan.
Ještě nadechnout a nevydechovat. I ask to take a deep breath, not to breathe out. Here is the stomach, the spleen, and here is a large cyst within the spleen. Here is the infiltration. This is already the suprarenal gland on the left side, and here you see the infiltration from the mass, which is around the celiac trunk. I will show you the mass after that, but already through this window, you see how it infiltrates the suprarenal gland, which is there. This is the mass around the celiac trunk. Here you see this irregular tumor, but first the kidney. This is the left kidney. This was the cyst, and this is these are the dilated calyces and the sinus, and you will follow the ureter here to the pelvis just to know where is the stop. So you go there and you see, just to be sure where is the ureter. You can of course use the color Doppler. You see, so this is the ureter, and I will show it to you that here the ureter is, there is some stricture of the ureter. Here is already the left ovarian tumor. So here is some stricture of the ureter, and there is dilation grade 2 of the left kidney. And now just to the right side, here is the normal kidney on that. So this is the normal sinus, no dilation of the calyces. And I would like to go now in the sagittal plane here to the midline, and here you will see, unfortunately, there is really infiltration. Perhaps I will go now in the transverse plane first, that you can little bit identify the celiac trunk. Sorry, I try it with the color. Nedýcháme. So now you can see the celiac trunk like the nedýcháme, like the bird wings, that you know where I am. And the celiac trunk is really embedded without the tumor. So this is the tumor, and you see the celiac trunk is there, and just here, this is the thrombus, which is perhaps the tumor thrombus in the left renal vein. Martinko, vyřiď to, jo? Martin, vyřiď to, jsem. And this is the thrombus in the left renal vein.
And can we see Doppler imaging of this thrombus?
Yes. And
Yes, thanks.
here, you see this is the left renal artery. Here would be the cava, and you see this is the thrombus. So here where we are, that you know, this is the aorta, the thrombus in the left renal vein, and here unfortunately I showed you the celiac trunk, better visible with the color. You see the birds of the wing, like here, one and the second, and it is embedded within the solid tumor, which is absolutely irregular, irregular growing here around the celiac trunk. You see it there. So this was the tumor, why she was diagnosed with the recurrence, it was there. And now probably because of the time, of course we have multiple lymph nodes, etc. But because of the time, perhaps we should move now to the TrueCut biopsy, if you agree.
Of course, I see no questions regarding the live scan or the staging using ultrasound, so we can proceed to TrueCut biopsy.
So I will give the microphone to the Roman.
So it will be transvaginal TrueCut biopsy. It will be performed by my colleague Roman Kocian. I think we will see and hear him.
Philip, I'm here. I can hear you properly.
But
we are ready for the TrueCut.
We have no images from the examination room. We have to wait for them.
We'll switch.
We have the transmission from the camera in examination room, and we need to see the ultrasound screen as well. So please, is it able to visualize to have the ultrasound screen?
Yes, we are here ready for you.
Now
maybe first we can
everything is prepared. So it's yours now, Roman, and please go on.
Let me show you what is necessary, what is needed. We need a gun. We can choose between 15 and 22 millimeters. I mean the length of the shot. We need a needle for vaginal TrueCut, a syringe with formaldehyde and vaginal disinfection, and some leader which will lead your needle. So let me first do the vaginal preparation. Tak hodně pokročíte, já vám jenom dezinfikuju jo, trošičku zatlačím tamponem, bude to.
So we use disinfection to prepare the vagina.
And please always speak with your patient. We spend like 10 minutes outside the room, discuss what will happen, all the steps. So she is, I think, pretty ready for the TrueCut biopsy. You should keep your at least end of instrument sterile. So it's somehow semi-sterile procedure. We don't need any bowel preparation. We don't need any we can give patient analgesic painkillers before the procedure, especially with the next one when we plan to do the transrectal procedure. So now we are ready. And we have bilateral solid ovarian masses, and they are both well accessible, so approachable, so we can choose between left or right ovary. I will load the gun. I will tell the patient that she will hear quite loud noise. To je ten zvuk hlasitý, takhle to vystřelí, jo? Řeknu vám. So I think she's pretty ready for the biopsy, jo? So, ne, obraz potřebuju.
Yeah, wait a minute, please. We need to see the ultrasound screen again. So we are waiting for now we can see the ultrasound findings. So yes, now it's everything prepared. And go on, please.
And always, there are few good recommendations. Try to stretch the vaginal wall as much as possible. I have the impression the better stretched vaginal wall, the less painful the procedure is. Make your mental plan. Prepare yourself. Okay, so we have a left ovarian mass. Do we have any dangerous organs in the way? There is a bladder. Bladder is not on the way. We can see the ureter. We'll also go laterally to ureter, and now it's quite close, so it's pretty safe. So no, I will just do it like this. Tak připravit, teď to píchne za chvilinku, jo? So I told the patient that she will feel some pain. I keep my hand stable. I press against the tumor. A teď ucítíte píchnutí, teď, jo? I can see the tip of the needle now. Do you see it? A teď to píchne, jo? Teď. Dobrý. Okay, and we are in the tumor. You can very safely see the tip of the needle. We are in the left solid mass. Teď to vystřelí, jo? And now we will shot the sample like this. It's safe. Máte to za sebou, jo? To je první vzorek. Tak, odpočívejte chvilinku. Tak.
So we have the first specimen. We just check it. And we usually repeat the procedure for 2 or 3 times, but Roman can continue. Okay.
We decided we will do only 2 shots. The reason is I have pretty good sample for the first one, and this is a solid tumor sample, 1 centimeter long and few millimeters thick, so it's enough. So the last, poslední biopsie, jo? Jdeme na to, ready, připravena. The patient is ready. Zase tlačím, jo, připravit. So I'm ready to insert the needle. I will take the patient. She will be. I'm pushing my hands against the vaginal wall. Tlačím, jo. Now you can see the tip of the needle again. We are here. Teď to píchne teď. Dobrý. We are in the tumor, and you can choose the central part, the lateral part. It's up to you. We can even put some color Doppler, but I don't like it. I just make my concentration less, and the tumor is bleeding. This is a very color score 4 tumor, so I think it is not very helpful in this situation. So, and we have a sample done. And now the very important thing is to check the complications. So check the internal bleeding. You can see sometimes, you can close it. You can see sometimes, we call it whirlpooling, blood whirlpooling, some little whirlpools of the blood, and we know it's completely not dangerous, and it's safe. So I can't see an internal bleeding. You have to tell the patient that she will have some not severe spotting or vaginal bleeding for a couple of hours or maybe 1 or 2 days. I mean, spotting, and you have to tell her that it is completely not dangerous. So the procedure is done. Děkuju, je to hotový, super.
Okay, thank you, Roman. I would just add that we do use Doppler to visualize the tumor, but not because of the risk of bleeding, in fact, but because of to find out where the vital portion of the tumor is localized. We need to avoid the necrotic tissue because it's not adequate for the histopathological examination. We do need a vital portion of tumor, and Doppler to see the vascularization can be helpful to locate the appropriate portion for the biopsy. So we finished the live scan for advanced ovarian cancer, and you've seen the first TrueCut biopsy, which is planned for today, the first one from the 3 ones. Now I can ask Daniela if you have some comments or other. No comments for us. So I think we are still on time. There are some questions. Do you always sample the tumor? Are there any issues with inadequate sample for the pathologist necrosis? I think it's a question I have already answered. Yes, the necrosis is our enemy. We try to avoid this necrotic portions. Sometimes we use Doppler to see the vascularization, and vascularization usually means that the tumor is vital in this portion. And you will hear about the adequacy, accuracy, and safety of the procedure in general during my presentation, of course. Okay, so now it's time for break. We need it, and we are still on time, so we can have the break for 15 minutes. So we meet again in 4:15 for Central European time. Okay. So good evening. Now we have the final part of this day, which will be about TrueCut biopsies and in general about minimally invasive procedure guided by ultrasound. In this lecture, I would like to talk about ultrasound as a reliable tool to navigate many minimal invasive procedures in gynecologic oncology. As you know, ultrasound, it's well tolerated by the patients. It's widespread. It's associated with lower costs than other imaging modalities. And of course with no radiation burden for the patient. So it could be the method of choice for the navigation of minimally invasive procedure. In which fields we can use ultrasound? Diagnostics as well as therapy and palliative care. I would like to focus on diagnostics. TrueCut biopsy is a mainstay of the diagnostic procedures guided by ultrasound. As you know, the histologic verification or histopathologic verification is absolutely necessary precondition to start the treatment of any solid tumor, and is the same in gynecologic oncology, of course. TrueCut biopsy enables to obtain the representative tissue of the tumor for histopathologic examination, not only morphological examination with many different stains, but immunohistochemistry or next generation sequencing. And it's very important in this era of modern targeted therapy for us. It's different from fine needle aspiration biopsy because based on FNAB, fine needle aspiration biopsy, we can get just the clusters of cells or isolated cells which are not suitable for the detailed histopathology examination, but cytology only. So, in general, what should ideal bioptic method look like? It should be minimally invasive, which means that it shouldn't cause any severe harm to the patient. It should cause no delay of subsequent treatment. It should be done on outpatient basis. It shouldn't affect the performance status of the patient. No need for general anesthesia. It should cause no unnecessary spread of tumor cells. However, it's a bit tricky. If you have advanced cancer of any origin, it means that the dissemination is already present, and the worsening of prognosis by the iatrogenic spread is not important for the patient in this case. So this is the special situation in early stage disease with the tumors with intact capsule. Then we try to avoid biopsy with the iatrogenic spill of tumor cells. But in advanced cancer, it's absolutely different situation. Nor laparoscopy, neither laparoscopy nor laparotomy satisfies the requirements for ideal bioptic methods. I have to admit that some centers prefer laparoscopy or its modification called diagnostic open laparoscopy to stage the disease and histologic verification in one step. It can be a good solution in some cases. However, this procedure can be replaced by the modern imaging method plus TrueCut biopsy. TrueCut biopsy is now preferred bioptic method over the fine needle aspiration biopsy, and I told about the reasons for this statement. TrueCut biopsy enables to get the cylindric compact tissue sample from the tumor. This cylindric tissue specimen is about 1.4 to 2 millimeters thick and about 10 to 22 millimeters long. So it's sufficient for the pathologist to establish the diagnosis from this specimen. Of course, the worst case is a diagnostic explorative laparotomy, just to see that there's a non-resectable, inoperable disease, and that's all. So true cut biopsy is different from fine needle aspiration biopsy, as I said. Here you can compare the typical specimens. In case of true cut biopsy, we can use all possible stains. We can apply immunohistochemistry. We can do next generation sequencing. So in majority of cases, this bioptic examination is sufficient to establish the diagnosis. Here you can see the needle which is used in a true cut biopsy. It's a thick needle, absolutely different from the thin needle used for fine needle aspiration biopsy. It consists of two different parts. There is an inner notched cannula. Here is the notch, and the outer case with very sharp edges or margins with this sharp tip. The tissue sample is then localized in this notch, and it's covered by the outer case. Then it's withdrawn from the tumor and immediately placed to the formalin. We have quite a huge spectrum of needles which can be used for true cut biopsy, or so-called core cut biopsy is the synonym. For transvaginal or transrectal approach, we usually use long needles, about 30 centimeters in length, which are thinner than the others, 18 gauge only. These needles are suitable for transvaginal or transrectal approach. The other needles are suitable for transabdominal approach. We usually use a bit shorter needles, 20 centimeters, but a bit thicker than the previous ones, 16 gauge. Very rarely we use 14 gauge, really thick needles. 16 gauge is enough for transabdominal approach. What is the bioptic gun and what it looks like? Here you can see the examples of bioptic guns which can be used. The majority of these bioptic guns are reusable, of course. You can choose between two different lengths of shot. The length of shot means the length of the tissue, or in other words, the depth of penetration into the tumor. We use predominantly this green bioptic gun, where you can choose between 15 millimeters or 22 millimeters. So it's the length of your tissue sample you can get after the end of procedure. The bioptic gun has a spring-activated mechanism inside, which is responsible for the shot, and it's based on standard, simple mechanism. How to use the bioptic guns and the needles. For transvaginal or transrectal approach, we usually use special guides which can be attached to the endovaginal probes, and they can ensure the safety of the procedure, as well as they are very, very similar for the instruments used for ovarian pickup. If you are familiar with ovarian pickup, then the transvaginal true cut biopsy can be very easy for you. Regarding transabdominal approach, the biopsy can be done from freehand without any guide, or you can use guide, once again inserted or firmly attached to the convex abdominal probe, and you can be then sure that everything is like standardized. So this procedure is very similar to chorion villi sampling or amniocentesis. So once again, if you are familiar with these procedures from perinatology, then transabdominal TrueCut biopsy can be more easier for you. So this is how to perform the transvaginal or transrectal and transabdominal TrueCut biopsy. And here in this video, you can see the whole process of TrueCut biopsy. At first, the needle is inserted to the edge of the tumor. We can see the tip of the needle and the edge of the contour of the tumor. Then you push the trigger, and you can see the shot of the internal or inner notched cannula inside the tumor. The second step, the outer case, or it can be called sheath. It's shot again, and it cut the tissue and cover the tissue inside the notch. The whole needle is then withdrawn from the tumor, and you can check your specimen if it's sufficient, if it's not only necrotic tissue or pus, blood, and so on. I strongly recommend to check it every time you have a new specimen to be sure that you have adequate tissue sample. And now the indications. So the most frequent indication for TrueCut biopsy in gynecologic oncology is suboptimally operable or inoperable advanced gynecological tumor, predominantly ovarian or tubal cancer. So the TrueCut biopsy altogether with the scan, ultrasound scan, is the first step, and then we have to wait for the histopathologic examination. It usually takes about 7 days, and after that we can start the treatment, usually neoadjuvant chemo. There are other indications, less common, but still very good proportion of our patients undergoing TrueCut biopsies. Suspicious non-gynecological tumors or duplicities, pelvic metastases in patients with already known non-gynecological tumors, suspicious recurrence of gynecological malignancy. In some cases, it's obvious that it's a relapse of the disease, and it's no need to do the de novo, new, fresh biopsy. But these days, in the era of targeted therapy, we should repeat the biopsy, or we have to repeat the biopsy of the tumor in recurrent settings because of the targeted therapy. So we need to find any target which could be used for the selection of the appropriate targeted treatment. And of course, another indication, patients in poor performance status, which means patients not suitable for any surgery, but suitable maybe for palliative chemotherapy. As I said, solid tumor, we need to verify the histopathologic behavior and the origin of the tumor to start the treatment, so it can be another indication. And in our large study published in 2010, we illustrated this situation. About more than half of our patients were patients with inoperable advanced gynecological tumor. 1/3 was represented by the suspicious duplicity, any other synchronous tumor. About 25%, 1/4 suspicious extragenital tumors, and another quarter suspicious recurrence. So it was about indication. Are there any contraindication? Of course, they are. The absolute contraindications are related to the hematologic disorders or coagulopathies, namely thrombocytopenia or the coagulopathies with the elevated international normalized ratio. In many cases, these conditions can be overcome by hematologic intervention, for example. After the appropriate preparation by the hematologist, the patient can undergo the TrueCut biopsy. And there are several relative contraindications for TrueCut biopsy. It can be the risky location of the lesion. Then in case of suspicious hemato-oncological disease, namely lymphoma, the TrueCut biopsy is not the method of first choice. We usually prefer to do the extirpation of the whole lymph node, which enables to which increase the probability that the histopathologic examination will be conclusive. And of course, as I said, early stage of disease with malignant tumor with intact capsule, no signs of other spread, then there is a risk of iatrogenic dissemination of the tumor, which could cause the upstaging and worsening of the prognosis. In these cases, the primary surgery is preferred, of course. So let's go to see the first clip. It's about a transabdominal scan, and I think you will see it in this live scan or live demonstration, which will follow after my lecture. What to say? So you can see the needle, and you can see the tip of the needle, which is firmly attached to the edge of the tumor. Then the shot, in this case 22 millimeters, because it's huge lesion, so we can go for the longest shot at possible in our settings, 22 millimeters. And you can see the needle for the whole procedure. So it's under absolute ultrasound control for the whole procedure. Another clip, transvaginal approach, transvaginal TrueCut biopsy from the lesion which is localized in pouch of Douglas. I use this orientation. It could be upside down for many of you, but I have to say it doesn't matter what orientation of the probe you use, and it doesn't mean that the biopsy must be done in this orientation. You can use absolutely different. So once again, needle, we can observe the tip of the needle. We try to avoid any necrotic portion of the tumor. You can see the cystic areas inside the tumor, which represent the necrotic parts. So we try to go through the solid portion, definitely solid portion, not cystic one. And if you use Doppler, use the vascularized, richly vascularized region. And then the last scan, it should illustrate or demonstrate that the TrueCut biopsy is really precise procedure in which you can choose different length. You can see the needle for the whole time, for the whole procedure. So you can take the biopsy even from this relatively small lymph node localized in obturatory fossa. Of course, we know that this is external, the external iliac artery, but we are far enough from it. We know that there will be 15 millimeters of length or depth of the penetration, so it's still safe. It can be considered safe for us, and we can perform the TrueCut biopsy even from this lymph node. So what is the outcome? What are the results of TrueCut biopsy? We have published a large study on the outcomes of TrueCut biopsies. It was about 190 patients enrolled in this trial, and the adequacy reached in this study was pretty high, 94%. And what does it mean, adequacy? Adequacy means that the pathologist is able to establish the diagnosis from the sample. It doesn't matter if it's this, if it correlates with the final histopathologic examination, but pathologist is able to establish the diagnosis. The insufficient samples were caused mainly by the necrotic portions of the tumor. What about accuracy? Accuracy is pretty high as well, 98%. Only 2 disagreements between the histopathologic examination from the TrueCut biopsy and the final histopathologic examination from the large sample. The typical tumors associated with these disagreements or typical tumors very difficult for pathologists to assess from small specimen include mucinous tumors, very difficult for them to distinguish between benign, borderline or invasive if they have just small sample, and leiomyosarcomas, another tumors included in this group with lower accuracy. And then we can say that the TrueCut biopsy is a relatively safe procedure. From the whole study population, 190 patients, only 2 cases with severe complications. So it means about 1% of any severe complications. And what complications can be expected after the TrueCut biopsy? Usually bleeding. Bleeding can cause hemoperitoneum in some cases, but very few cases. The surgery is necessary, laparoscopy or laparotomy. As you can see from our series, this severe complications were in patients with thrombocytopenia or with other coagulopathies. In advanced stage of disease, you can expect the bone marrow tumor infiltration or the liver metastases, even the chronic disseminated intravascular coagulopathy in some cases. So yes, in these patients, it can be a bit more risky. Other mild complications include, for example, vasovagal syncope with bradycardia or infection. Here I would like to say that the TrueCut biopsy can be done even through the wall of urinary bladder. Of course, we try to avoid this way if it's feasible. But yes, can be done through the vaginal wall, and of course it can be done through the wall of the bowel, which is typically in transrectal approach. But still, the infection rate is not significant, and all these infections are mild. So bleeding complications are the most risky or the most severe you can expect, but still very rare. And methodology. So ultrasound-guided biopsy can be done immediately after the first scan. Informed consent is necessary. It's an invasive procedure. The patient should be well educated and instructed about the whole procedure and the early, even late post-procedural period. We usually want to see the current blood count and coagulation with INR and APTT. There's no special preparation requirements in TrueCut biopsy, no fasting, no bowel enema, even in case of transrectal approach. According to the localization of the tumor and its size, you have to choose the appropriate diameter and length of the needle. At first, at the beginning of the procedure, please test the biopsy gun if it's working, if there's no malfunction, and select the penetration depth. Appropriate aseptic technique. Of course, we use local anesthesia for transabdominal puncture, but not in other approaches, transvaginal or transrectal. Prophylactic antibiotics can be recommended for transrectal punctures, but still represent optional step, not mandatory. And it still depends during the transrectal approach if the tumor is localized just in the wall of the rectum or very close to the wall of rectum, or so it's one group of cases, or if it's localized a bit more far from the or remoted from the wall of rectum, and you have to go to the peritoneal cavity. Then I would strongly recommend to use the antibiotics in case of transrectal puncture and intraperitoneal biopsy. So the whole procedure is under ultrasound control. You have to avoid necrotic tumor tissue, use Doppler to see the blood supply to be sure that you are in the vital portion of the tumor. Multiple needle courses are necessary to obtain the adequate, representative and adequate histopathological specimen. We usually repeat the biopsy, the shot 3 times to be sure. The samples are fixed immediately in formalin. What about the aftercare is usually not necessary. It's an outpatient procedure. We just recommend to stay in waiting room for other 30 minutes after the procedure. And it was about the TrueCut biopsy, which is really the mainstay of this diagnostic procedure and all minimally invasive procedures performed in gynecologic oncology. In the last part of my presentation, I would like to focus on therapeutical purposes. So the minimally invasive procedures guided by ultrasound can be used for therapy or palliation, namely punction and drainage of the lymphocytes, abscesses, seromas. We can use ultrasound to minimize the harm of the patient in post-operative period when we face these complications. So lymphocytes, I think that you are familiar with the typical ultrasound appearance of lymphocytes. They are usually localized in pelvis. Now we live in the era of sentinel lymph node biopsy, so the incidence of lymphocysts or lymphocytes is lower and lower. However, there are still indications for the systematic pelvic lymph node dissection. So I'm sure that you will see some lymphocysts. The incidence after the systematic lymphadenectomy is considered to be in very wide range, 1 to 60%, but the majority of these lymphocytes is asymptomatic. In some cases, we can observe symptoms related to lymphocytes: pain, acute lymphedema, dysuria, ureteral obstruction, or infection. And these symptoms can cause the delay of subsequent treatment, or they can be then the lymphocytes can be misinterpreted as recurrence, which means another harm to the patient. So what to do with the symptomatic lymphocysts? In our big study of about 800 patients after pelvic plus minus para-aortic lymphadenectomy, we focused on pelvic lymphocytes, and we could see that there is about 20% of patients with some lymphocysts in pelvis, but only in about 6%, 46 patients, these lymphocytes were symptomatic. They can be associated with so-called bulky symptoms, which means the compression of the surrounding neighboring organs, ureters or bowel, small intestine, or they were inflamed. They were associated with inflammation, and then in some cases even sepsis. So how to treat them? Of course, we can do the rail laparotomy or laparoscopy to try to find the lymphocysts and do its marsupialization, application of some material to stop the lymphoria. But it's as I said, still in patients in bad conditions with oncologic diagnosis, and there is a high risk of delay in treatment. So we can do some minimally invasive procedures. And I would like to introduce this set, which is used for suprapubic cystectomy, and I think you know it. And it can be used for the punction and drainage of the lymphocysts as well. The ultrasound navigation is necessary because of the risk of other injuries to the bowel or to the other organs. So this catheter can be inserted into the lymphocysts and left there for usually 3 days. The suction drainage is necessary to cause the collapse of the lymphocysts. And in this clip, you can see the trans-abdominal punction and drainage of the lymphocyst. This lymphocyst is pretty big, but it originates from obturatory fossa. So under ultrasound control, we can insert this thick catheter, and it's left there for at least 3 days, as I said. Then you can expect that the cysts can resorb after that. In case of inflammation, the risk of recurrence is higher than in other symptomatic cysts, but still this punction and drainage under ultrasound control can be the first step procedure. In all cases, regardless if infection present or absent, we recommend to give antibiotics because of the high risk of infection in lympha, which is rich in proteins and so on. And this is how it looks like after the drainage, after the punction. And as I said, the suction drainage is necessary to ensure the collapse of the cyst. And absolutely last part of my presentation will be about the palliation. We use ultrasound to navigate the appropriate location for permanent peritoneal catheter insertion. As you know, the malignant ascites is very common in ovarian tubal cancer, and in patients with best supportive care, it's one of the most important limitation of their quality of life. And if you compare the patients with repeated single punctions of ascites with the patients with inserted permanent peritoneal catheter, you can be sure that the quality of life in the second group with the permanent peritoneal catheter is significantly higher. There are evidence which is clear. So this is the typical sign we have to face in these patients: malignant refractory ascites, and no other specific oncologic treatment, just best supportive care. So in these patients, you can use some sophisticated methods such as permanent peritoneal ports or peritoneal venous shunts. However, they are costly, they need hospitalization, general anesthesia, and they are still associated with severe complications. Instead of that, you can use tunneled peritoneal catheters, which has still very good efficacy. And they are not so costly. They can be inserted during 1-day hospitalization with no general anesthesia, just analgous sedation. They are routinely used for peritoneal dialysis, so there is enough experience with their insertion, and we have evidence that in huge number of patients with refractory malignant ascites, they are really working, and they have very good effect on their lives. The special feature of these catheters, it's a cuff which is localized in 2 different positions. This so-called Dacron cuff is then localized in peritoneum and in subcutaneous tissue, and this cuff or tool, so these cuffs are responsible for the minimal risk of infection or leakage. So the duration of the catheter is ensured due to this special cuffs. Indications for permanent peritoneal drainage. It differs institution from institution. At our site, we usually recommend these permanent peritoneal catheters in patients with the life expectancy of 4 weeks or more, with no option of water cancer treatment. So we can't expect any effect of chemotherapy because we plan no other chemotherapy. And in patients with recurrent ascites requiring evacuation every 7 to 14 days. This is the catheter. It's called swan neck catheter, and here you can see the 2 cuffs, Dacron cuffs, which are the most important part of the catheter because they can ensure the long duration and very low complication rate, no infection, no leakage. And in this last video, I will show you the whole process. We use ultrasound to select the appropriate location of the catheter. We try to avoid the locations with the tumor, with the adhesions, or with the infiltration of abdominal wall. Then the ultrasound is placed in the operation theater. We can use it intraoperative or operatively, and after this preparation, the catheter is inserted. We can be sure that in correct place, and the patient is sent home next day. So it's usually next day or in the evening of the same day. So one day surgery. Thank you for your attention. It was the last clip and last picture of my presentation. So now we can proceed to the live demonstration. But there are questions, so
Philip,
I will answer.
Here is a question. Whether you make the biopsy from the tumor itself or from the metastasis, and whether there is high likelihood of receiving insufficient sample if you do the biopsy from some critical sites.
It's very good question, and it was another issue we tried to investigate during our study. So now we know that the adequacy and accuracy of biopsy is the same for primary tumor site, ovary usually, but any other primary tumor, and carcinomatosis in pelvis. So we can say that the transvaginal approach is a bit more accurate than transabdominal. Yes, I must admit. And there are no differences between the primary tumor and carcinomatosis in pelvis. There is slowly lower accuracy of true-cut biopsies from omentum, and the worst results, worst adequacy, it's for the true-cut biopsy from lymph node. So in my opinion, as far as I'm concerned, I would prefer the transvaginal approach, but of course, if it's necessary, then transabdominal, and then primary tumor or pelvic carcinomatosis, if it's feasible. Then something. The second part of the question was about insufficient sample. So there are no significant differences between transvaginal and transabdominal approach. The needle for transabdominal approach is a bit thicker, but then it can be a bit more difficult to get the adequate sample. So the results are the same for transvaginal and transabdominal, but yeah, that's it.
There is another question, and this is about whether you have ever had inflammation of the skin after catheter insertion.
Yes, so of course it's I've said it's the permanent peritoneal catheter has long duration, very low risk of infection or leakage, but it means it's not zero. Yeah, so there are still cases of infection of the wound, even peritonitis after the insertion of catheter can be observed. By the this risk is very low. And as I said, we use these special catheters for peritoneal dialysis. So it's they are safe, but the risk is considered to be about 0.5% as it's from literature.
Excellent, thank you. So I think that they are ready, so you can then introduce your patient.
Okay. So now I would like to introduce the first patient, which will undergo the true-cut biopsy, and it will be transabdominal true-cut biopsy. It's a 66-year-old patient sent from our medical oncology department with the diagnosis of breast cancer. It's a BRCA negative patient. The first diagnosis from July 2006. And as you can see, she was treated by surgery, adjuvant chemo, radio, and endocrine therapy. The first recurrence occurred in January 2017 during the on CT scan, disseminated disease with the metastases in lungs and bone, vertebral column. Chemotherapy of second line, another endocrine therapy. However, progression of disease in April 2021. According to CT, new carcinomatosis in abdomen and pelvis. Other lesions were stable. You can see the list of other therapies she had to undergo. And now we have the current CT from the 2nd of November this year, and it shows the progression of carcinomatosis and omental cake, while other lesions are stable, including lungs, lymph nodes, or bone metastases. So she was sent by her oncologist to exclude any duplicity or specifically ovarian cancer. I can share with you the CT scan which are available. You can see the arrows, and these arrows represent the lung metastases. It's in this location, sorry, now lung metastases, and pleural carcinomatosis with pleural effusion. It's on the right side, so in the right thoracic cavity. Then we can share with you the osteoplastic metastases in vertebral bodies. They are osteoplastic, so the density is thicker. Then you can observe the nodules in supracholic omentum. And sorry, this is the omental cake in infracholic omentum, and here you can see the smaller nodules in supracholic omentum. However, it can be considered the omental cake, infiltration of both supra as well as infracholic omentum. Then the paracholic carcinomatosis on both sides. Oh, sorry, this one and this one. Yes. Once again now, and small bowel carcinomatosis as it's localized here around the loop of the small intestine with the irregular margins. It's the first patient, and I think that she is prepared as well as Dr. Kocian. So we can go
Philip,
to the examination room. Yes, Roman.
Do you hear me?
Yes, we can hear you clearly.
So we are ready with the patient. Again, informed consent is signed. We spend again quite good time in the clinic and discuss all aspects of the procedure. This case will be the transabdominal approach, as you presented before, that the patient has nearly no ovarian masses. So transvaginally, there is no tumor to be for the biopsy, but omental infiltration is very well visible and clearly approachable. The patient has also quite high BMI, which makes the procedure a little bit more tricky, but I believe it will be very nice case to show you how to do the transabdominal biopsy. So let's repeat again what we need. We need gloves, a sterile table with needle for transabdominal true cut, which is shorter and thicker. We need a local anesthesia, true cut gun, and some disinfection. So syringe první. Tohle nebudeme potřebovat. Aha, takhle. Good. So we will just prepare some local anesthetics. And then we will start the procedure itself. Maybe it will be a abdominal true cut biopsy from freehand. And as Philip showed you before, we have nearly two options. You can use a guidance or the special equipment on the top of the probe, and even you can do the freehand procedure. And it's also good to have a skilled nurse by your side, who is very helpful for the patient. And I will need a disinfection. If you can give me some disinfection in this area above the umbilical, and even just put it on the probe. Good, yeah. And as you can see here, you can see the abdominal wall, and there is also skin, fatty tissue, underlying fatty tissue. Then you can see easily hyperechoic fascia, and you can see the peritoneum. And then what is moving down below is omental cake. It's infiltrated omentum, and there's a little bit of ascites, like the hypoechoic layer just beneath the abdominal wall. So we are ready. So make a plan. Okay, so we will need to go a little bit above the umbilicus. I'm now pushing with my finger. you can see the direction. So the deeper you are going, the more blunt angle, the superficial, the more sharp angle you will need. So, okay, we have a plan. Okay, so now I will tell the nurse that we will use a disinfection and local anesthetics. Teď to trošku pichne, jo? And I believe you will be able to see the needle for the infiltration. And you can see how I am infiltrating with the needle. Yeah, this is me. You can see the tip of the needle. You can see the tip of the needle, and please, now you can see very nicely the tip of the whole needle. And I will even try to infiltrate the fascia, and I'm now pushing the local anesthetics at the place where I will insert the needle for the true cuff itself. So yeah, nicely visible. Dobrý? V pořádku, to je to omrtvení, aby to nebolelo, jo? Always keep a contact with the patient so she can know what you are doing. Good. Good trick is to leave the needle inside, so you will not forget when do the true cut. We'll prepare the gun with the abdominal true cut needle. Again, I think that 22 millimeters is okay for the patient. It's functioning. Again, I will ask the nurse if she can put some disinfection, and if I will take the needle out. Teď to trošku pichne, jo? Připravená? Okay, you can wait a little bit. We still have time, so we will wait until the local anesthetics will start working. So we can maybe wait a little bit more longer. Nebolí to? Takhle to je dobrý, jo? Super. Okay. So I believe the patient use oral novel anticoagulants. So we ask her to not to use it today, and she did it. She has normal full blood count and also normal coagulation. And I think we can proceed with the biopsy now. Teď to trošku pichne, jo? Teď jo? Super. Šikulka. So now you can see my needle going inside the, trošku desinfekce přes to všechno zase, jo? Going into the fascia now. I can feel with my hands that I'm on the fascia, even have some tactile perception. Okay. And I will now go beneath the smith. Now we are in the abdomen. I can still feel it. Zase desinfekci. And I can see the needle just in the omentum. I will make the angle more superficial. Now I will shot. Yes. And we are now in the directly where I want it to be, in the omentum. Tak to máte poprvé, and now we will repeat it ještě dvakrát, jo? 2 more time. Good. Nakloň to trošku na mě. We have a pretty nice fatty sample, and we will proceed ještě dvakrát, jo? Jdeme? Připravena? Again, I can see my needle. Now I will go through the fascia. Boom, I'm in the omentum. I will just shot it. Boom, we have a nicely visible needle. Now you can see pretty clear the whole needle in the omental cake. I will now go out, and you can see how I'm leaving the abdominal cavity. Now I'm at the level of peritoneum, fascia, subcutaneous tissue, and I'm going out. And the last one, a naposledy ještě, jo? We have pretty good samples. The last biopsy. Ready? Připravena? You can see the needle going inside. Very important is to feel the tactile perception, not only the ultrasound picture, but also the impression with your hand, that you can feel that you are on the surface of the fascia. I can feel it, so I will go through it. I'm in the momentum now. Make the end angle appropriate, not to harm any bowel beneath. Now I can shoot, done, and it's done. We have all 3 true cuts done. And I'm leaving the abdominal cavity. It's bleeding a little bit, but it's still okay. So I can apply some compression, and it's over. Děkuji. Tak je to všechno.
Roman, can you hear us? Please,
I can hear you.
can you please emphasize that it's really one-hand procedure, that you have the probe in one hand and in the second you can really use the instrument, taken the sample and expose the sample, that you don't need to change the hands. In one hand you have always the probe.
This is really essential. And very essential is to try to keep the ultrasound probe and the needle in parallel, otherwise you will lose the orientation. You still need to know where the needle is and choose the good angle and don't rush. There's a lot of time and you think twice and then do the true cut. Was it painful? Bylo to bolestivé? And I asked the patient if it was painful, and she had no pain. So thank you very much. Any questions?
Yeah, will you observe the patient after the procedure or not?
She has a dinner with her family, so she needs to go, and I'm very happy she can leave the department directly.
So
because her son is already waiting her outside. So it was completely non-complicated procedure. There is no need to observe the patient, and I can let her go home.
yes, and because we have already the sample from her breast cancer, the histology result will be very easy because they will just compare the biopsy you have retrieved with the past biopsy of the patient. So we will know, I expect, in 48 hours whether it is the breast cancer or whether it is a metachronous cancer. And what's very important, we will also have the NGS, the tumor mutational burden for further biologic treatment, which is excellent. Thank you, Roman. It was a very difficult procedure and you did really dislike the artist. Thank you very much.
Thank you. Now, Philip is already here and we will prepare the last patient for the true cut for you. Thank you.
Yes, and I will just have a look whether there is not any questions from our colleagues. I will check it. Just a second. Now, and it seems we do not have any additional question regarding the transabdominal true cut biopsy, so I will introduce the last patient. I hope you have the patient already ready, so we can introduce her. So the last patient is a patient 67-year-old. She has the germinal BRCA2 positive mutation. And in her history in 2017, so 5 years ago, she was treated by primary debulking surgery for high-grade serous cancer stage 3A2. So it was a disease with really discrete spread of cancer in the abdominal cavity. It was mainly in the lymph nodes and eventually microscopic spread in the omentum or on the peritoneum. And there she was treated with 6 cycles of paclitaxel, and after 8 months she developed the first recurrent disease on multiple sites, sigmoid colon, lungs, lymph nodes, and she received the same regimen, paclitaxel, 6 times. After that, after 5 months, she again progressed, but only in the pelvis, treated with the weekly pacli plus bevacizumab, with another progression But then we decided, because it was only in the pelvis, that we will offer her secondary cytoreductive surgery and remove the tumor. So there was no residual disease in situ, and she received cisplatin biweekly regimen 12 times. And after almost a year, less than 1 year, she developed again the progression in the pelvis, and she received the third cytoreductive surgery with complete resection of disease in the pelvis. And she was not treated with the chemotherapy, and she was in the follow-up. And now she's completely asymptomatic, and in the follow-up, which was proactive follow-up, the CT was performed, and on the CT there is the bladder, the rectum, and behind the rectum there is a recurrent disease which is located presacrally. And this is the same here. Here will be the lesion. Sorry, with my pointer, here is the lesion. And I would be very happy if Philip will show us the pelvic scan. We don't have any other lesions except of pelvic lesion, one solitary lesion. So I will give now the word to Philip if he is ready. Can we now switch to the ultrasound room if it's possible? Philip, are you there? He will take the microphone probably.
Can you hear me now?
Yes, we can.
Yes. Okay. So we are prepared. So for now, it should be the third TrueCut biopsy of of today, and I expect the most difficult one. So it's a good time to do it. So you know the patient, and it could be the solitary lesion in pelvis. However, after many surgeries with frozen section, and this lesion is not available, or in transvaginal approach. That's why we have to use the transrectal approach. I will show you the transrectal scan of this patient as the first step, and then I will go for the transrectal approach, and I think you will see the important differences.
Philip, can we see now the ultrasound is performed transvaginally or transrectally?
At first, can you hear me? Now I will insert the probe transvaginally.
Transvaginally, thank you.
So now you will see the transvaginal approach. Dá se to zvládnout? Jo? Teď jsem v pochvě vyšetřuju.
Yeah.
Okay, so this is what can be seen transvaginally. Is the maximum we can get. There is a bit larger content in urinary bladder than I would prefer. But that's all what we can see. So now I insert the probe transrectally. Tak teď vyšetříme přes ten konečník, jo? Nebojte, zvládneme to, trošku víc gelu.
So did you ask the patient to be prepared for this transrectal scan?
For this transrectal scan, no fasting, no enema. The patient get painkiller. It was diclofenac per rectum about 30 minutes ago, and we gave her antibiotics, which was ampicillin plus sulbactam as a typical antibiotic prophylaxis.
Like single shot.
Like single shot, yes.
Thank you.
Dobrý, zvládáme.
So you just insert the same probe, the same transvaginal probe in the rectum. Is it true?
Dobrý. The same endovaginal probe is very gently and very slowly inserted into the rectum, and the patient is educated about the course of the. I will try to find the lesion now.
Yeah, so now we are in the transrectal approach, and it has advantages that we can go usually more deeper with the probe, and we can also go more closer to the pelvic side wall if it's needed. But now it depends how deep the lesion will be. On CT it was slightly higher at the level of the rectosigmoid, I suppose.
I will try to find it once again.
And the biopsy, it will help us first of all to confirm the presence of recurrent disease before the fourth site-reductive surgery, but also, of course, we can use it in case we would not plan the surgery. We would use it for the NGS, for tumor mutational burden.
Okay. Okay, so I found it. I was a bit confused, but now it's okay. So I have it. This is the lesion attached to the wall of rectosigmoid, and I will measure the size of the lesion to choose the correct. We have 20 millimeters. 20 millimeters lesion, which is very, very, very suspicious of recurrence. And yes, I will take the biopsy from this position. I will use 22 millimeters of the length of the shot.
And which needle gauge will you choose?
It's still the same for transvaginal or transrectal approach, so 16 gauge.
16 gauge. So it means like 1.7 millimeter.
I just take a deep breath. Teď ucítíte jedno píchnutí. Výborně. A teď se ozve taková rána. Nelekněte se. To přijde teď. Okay, now the shot. So we were there. You can see it.
Will you show us now the sample that you use again? One hand procedure. We will switch the camera. May we switch the camera to the room to see?
We can switch the camera.
Yes. So again, in one hand you have always the probe, and in the second you have the automatic gun with the needle inserted in the automatic gun system. So always in your right hand you have the probe, and in the left you have the automatic gun, and you are able to use the automatic gun just with one hand. Perfect. Thank you.
So I will do 3 biopsies. Tak uděláme 3. Už máte jednu za sebou, je to výborný. Okay, tak nadechnout, zhluboka zadržíme dech. So the second one.
Here is beautiful core sample of 2 centimeter length. Thank you.
I hope you can see the screen.
Now we have the screen. We don't see the tip of the needle yet.
Now it's not so very well seen here, but I can feel it and I can see it. So now I will take the biopsy. Can you see it now? Yes, I think so.
Excellent.
Once again, the sample.
Okay.
And now we will take the last biopsy. Yes. The absolutely last, third biopsy from this lesion. Tak poprosím nádech. Zadržíme dech. I can feel and see the tip of the needle, and now there will be the shot. Yeah, I hope you can see it.
Yeah, we can. And
It's the last one.
Will you have a look whether there is some bleeding? Yeah, sorry.
Of course,
Okay.
I will check it. I don't expect some peritoneal bleeding in this.
Beautiful sample. It's a little bit white, really from the tumor. It's
Yes.
taken, yeah. Thank you.
I'm sure that we were inside the lesion. Sometimes you can see the lines of the previous biopsies as hyperechoic lines inside the tumor. So we have to wait. We have to wait for the results. However, there shouldn't be any intraperitoneal bleeding because we are localized in this presacral lesion. I would say subperitoneally. And of course, I will check the bleeding from rectum now, but it's done. The patient was very brave. And that's it. That's all. As you could see, the transvaginal approach was useless. It was not even tolerated by the patient. So we had to do the transrectal approach. But
can you switch your camera that we can see your face, Philip? Is it possible?
Of course, it is.
Thank you.
Okay, so now it's done. The patient looks okay. She will go home in about 15 minutes. There's no bleeding. I've already checked it, and we can expect the results in about 3-4 days. So that's it.
Thank you very much. It was excellent. So you use here the single-shot antibiotics. Do you use always the antibiotics for transrectal approach, or just if you pass in the peritoneum with the needle?
Yes, as I said, the antibiotic prophylaxis is optional. In this case, there was dubious if it's abscesses or not. So I recommend to administer to give the prophylactic antibiotics. Yes.
Any observation will be needed for your patient, Philip?
No other observation, as I said, just 15 minutes now to check the patient. If she's okay, then she go home. It's an outpatient procedure. And I do not expect any higher complication rate than, for example, for transvaginal approach.
Thank you very much. It was really lovely to see you performing the TrueCut biopsy, and would be very nice if you can join us for the short discussion at the end of the day. So Roman is there, Philip will be coming, and I didn't see any questions on the chat. If there would be any, we are very happy to discuss it. I check it once more, but still no questions. So to be honest, as David said, this is the procedure which we do frequently, because many colleagues from clinical oncology also asked us about the biopsy in their patients. Today you have seen 2 patients with progression of the breast cancer, and we have been asking to rule out the possible metachronous cancer, and we will also help them to provide the biopsy sample for tumor mutational burden. And because Roman is already there, I would like to ask Roman, what's the necessary prerequisite to do the safe procedure if you start with this procedure in your department? What you need to know, what you need to have as instruments, and how many biopsies should be performed to do it really safely. Here?
It's easy to answer. You need good teachers, Daniela and others. Then you need to start with more easy procedures. I mean, as we did the first biopsy from a pretty big pelvic mass close to vagina, close to the in the pelvis centrally, when there is no risk to injure any big vessel or ureter, and do it regularly, and that's the best way how to do it. And you need to keep how many procedures we are doing how many procedures every week? I think something between 5 to 6 procedures weekly.
This is what
Even it's not. It's quite unusual, but still we are even doing the true cut from the liver parenchyma. Personally, I was afraid to start to do the liver biopsy, but when you imagine how is the color score in the pelvic masses, especially from breast cancer or pancreatic cancer, that the ovarian masses are very tend to bleed, and if you are doing surgery in epigastrium, and you know that to make the liver to bleed is not so easy as to make the pelvic masses to bleed. So even the liver biopsies are, I think, pretty safe in our hands, I believe. But it's quite unusual. We don't do it very often. Yeah, and it's good to be also, I mean, the combination of to be a oncosurgeon and sonographer, it will help you to combine the direct visualization of all organs in the abdominal cavity or in the pelvis, combined with the visualization with the ultrasound. It's very helpful. Yeah.
So then the expertise is more faster. Yeah. And Philip, what about the biopsy of the lymph nodes in retroperitoneum? Is it possible? You have shown some video.
Yes, of course, it's possible. But as I said, the adequacy and accuracy of this specific location is a bit lower than in, than in other locations such as omentum or carcinomatosis. Yeah, but it's feasible. As other retroperitoneal biopsies, not only lymph nodes can be biopsied in retroperitoneum. There are a huge range of a bit rare retroperitoneal tumors which can be biopsied as well. And we as gynecologic oncologists have experience with these tumors. They are the part of our differential diagnosis. They can be very often misinterpreted as gynecologic cancer. Yeah, so we have biopsied many of these not nodes, but schwannomas, neurofibromas, and other retroperitoneal tumors. So I would say that from some aspects, the retroperitoneal biopsy is even a bit safer because there's no risk for peritoneal bleeding, and the surrounding tissue usually stop any small bleeding. But you have to know where the big vessels go through. So iliac vessels and their branches.
Yeah, thank you very much. So if we look on the frequency, probably the most frequent is the carcinomatosis of the pelvis. We take the biopsy, tumor itself in the pelvis. Then
like the primary site, yeah.
Then perhaps the omentum.
Yes.
And then the retroperitoneum and liver. Yeah.
We can do the true-cut biopsy even from the groin lymph nodes, from the inguinal lymph nodes. Then we usually use the linear probe for the navigation. Yeah, and it's feasible. It's feasible. You can do it.
Maybe Philip, can you just shortly comment? What do you think? If you just know you accidentally hit a small bowel, or from the final histology, occasionally we have like bowel serosa, or does the injury, for example, to internal iliac vessel, directly means that the patient will need laparotomy or will suffer from hemoperitoneum? Can you maybe comment shortly on this?
Okay, so don't be scared if your pathologist say there is a bowel in your specimen. It's possible. However, keep in mind it's 16 gauge. 16 gauge needle, very, very thin, and or 18 gauge, it's even thinner. So yes, you can go through the wall of the bowel, and it can cause nothing to the patient. So no symptoms. So of course we try to avoid the bowel or the small intestine if it's possible, as much as possible, but incidentally it can happen.
Yeah. So in reality, to conclude the TrueCut biopsy, the really prerequisite is to be the good sonographer, to find the appropriate location where you have really sufficient sample, and a sample which is from the proper tumor location. And that is, so this is really the prerequisite, to start with ultrasound, with the scanning, and then to join the TrueCut biopsy is then not so much difficult. Is it true?
Yeah, you're right.
Yeah. So now we didn't receive any further questions. If there are not questions, we have also our international fellows. If they are also do not have questions, I would see that for today we are ready. So no more questions. So we would like to invite you for the next day, which will start at noon at 12, and it will be starting first focusing on endometrial cancer. Then we will have cervical cancer, and at the end vulva cancer and the lymph nodes. So thank you very much for your attention. Thank you for beautiful TrueCut biopsies, for nice lectures. And if there is no more, I would like to close the first day of the Ivugo workshop. Thank you. Bye-bye.
Have a lovely evening. Thank you, Daniela. Thank you, Philip.
Thanks.